Annual Symposium on Global Cancer Research. We are going to get started in just a moment. I'm just going to walk through a couple of housekeeping notes for you right now. So all of the attendees will remain muted throughout the event today, and we are recording this event. So if you are a registered attendee, you will receive a link to the recording when it is ready. If you're experiencing any audio or video issues, you can visit the Zoom website listed here or stick a note into the chat box and we will try to respond to you. If you have a question for the panelists throughout today, please use the Q&A box seen highlighted here at the bottom of your screen. And we invite you to join the discussion on social media. On Twitter, please follow @NCI Global Health. We will be live tweeting throughout the event. Please use the hashtag ASGCR21. We were excited to see a lot of postings yesterday, including those of you with scientific posters sharing online. So thank you for doing that. Without further ado, I turn it over to our symposium host, Dr. Miriam Mutebi of the Aga Khan University Hospital in Nairobi, Kenya, who will start us off today. Over to you, Dr. Mutebi.
Thank you. Thank you. And hello, everyone. Good morning, good afternoon, good evening, wherever you are. And welcome to the second day of the annual Symposium on Global Cancer Research. If you were with us yesterday, then you probably had a chance to engage with all those dynamic dialogues that I would say, thanks to our 258 participants, we were actually able to continue throughout the course of the day. So thank you for that. And if this is your first day, dive right in. You are among friends. Use the Q&A function to make sure that your voice is heard. Now, this is the ninth iteration or the ninth year of the annual Symposium on Global Cancer Research. And this has consistently been the largest of the CUGH satellite meetings. The symposium is organized through a collaboration with the US National Cancer Institute Center for Global Health, CUGH, the Duncan Comprehensive Cancer Center, at Baylor College of Medicine, the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins University, the University of Texas MD Anderson Cancer Center, the American Society of Clinical Oncology, the American Association for Cancer Research, and international collaborators from both the Ministry of Health in Mozambique, the Aga Khan University Hospital in Nairobi, Kenya, and the Tulane Health Officers for Latin America. Now, yesterday we heard about the importance of building resilience in cancer research and cancer control activities. And we also heard from a cross-section of the 101 scientists who submitted abstracts to the ASGCR. And these are, really dynamic, thought-provoking, studies and new ways of looking at things. And so I would encourage us all. They have posters that are live throughout the symposium. So I just encourage all of us to take a look at them. Now, out of the gate, our amazing three keynote speakers made a call for robust collaborations and strong partnerships. And so on our second day, we turned to an equally critical component of these. And this is rotates around the issue of equity in global cancer research. Now, I'm sure for most of us, at the top of our minds, we're probably thinking, what does that look like in 2021? And I would encourage us all to sort of think about, just throughout the course of today's conversations, perhaps look at what the constructs you have around equity in your mind, and perhaps try and challenge them throughout the course of the day. Some of us think that, it's a function of geography, but irrespective of whether we're talking about access, whether we're talking about parity, or whether we're talking about representation, I think it fundamentally comes down to, well, for want of a better word, who's paying the piper, and sort of us taking a step back and saying, do we necessarily want to be dancing to that tune? And so I would say our seasoned lineup of speakers over the course of the day are going to highlight gaps that exist in global cancer research. But I think more importantly, they're going to work together with us to sort of look at how can we as a global oncology community work collectively to improve this key concern. Last but not least, and certainly the icing on the cake, we will close out the symposium hearing from two inspiring scientists who are the winners of the 2020 and the 2021 Rachel Perlin Award, an award that honors excellence and dedication to global oncology. And so to start us off, I'm going to hand over to Dr. Satish Gopal, who's the Director, Center for Global Health of the US National Cancer Institute. Dr. Gopal, welcome.
Thanks so much, Dr. Mutebi. So I think for that, great introduction. I was asked to chair a session focused on building towards equity, and so Dr. Mutebi alluded to this, but this is really where our focus is going to be over the next 90 minutes or so. I have to say, when the scientific program committee across the institutions that Dr. Mutebi mentioned decided to develop a panel that was specifically focused on this topic, and then asked if I would be interested in chairing it, I was both very excited and also anxious. Clearly, this, the concept of equity is something that is on all of our minds these days. I think many of us are having really important conversations about this topic within our own programs and institutions. And needless to say, we think these conversations are critically important for the work that we do at the NCI Center for Global Health. However, this is a fairly complex topic. I think these conversations can be quite uncomfortable. So we really wanted to engage in this in a, I think, deep and substantive way, acknowledging that doing this using a virtual format may be somewhat difficult. So I will certainly do my best to facilitate, again, over the next 90 minutes or so. And I'm pleased to be joined by a really remarkable group of panelists. So let me just briefly introduce them. I really could spend the next 90 minutes discussing each of their biographies, which I think will not serve the goals of this session well. So I'll direct all of you to their speaker bios, which are listed on the conference website, or a simple Google search, by which I think you can find out more than you would want to know about any of these remarkable individuals. But we've tried to really reflect geographic, topical, disciplinary heterogeneity within our group, and I think we've achieved that. So I'll be joined in today's discussion by Dr. Lisa Newman, who's the Chief of Breast Surgical Oncology Programs at the Weill Cornell Medicine and New York Presbyterian Hospital Network in New York, the United States, as well as Dr. Valerie Paz-Saldán, Director of Tulane Health Offices for Latin America at the Tulane University School of Public Health and Tropical Medicine in Lima, Peru. Dr. C.S. Pramesh, who's the Director of Tata Memorial Hospital in Mumbai, India. And finally, Dr. Verna Vanderpooy, who's a radiation oncologist at the National Center for Radiotherapy at Korle-Bu Teaching Hospital in Accra, Ghana. So I'm really delighted that we'll be supported in these conversations by this truly remarkable group. So the other thing we were hoping to achieve with this session is really to avoid, I feel like we've walked out on a limb a little bit in trying to structure a real dialogue that didn't rely on pre-recorded remarks or extended slide sets. However, I think just setting the stage before we begin with seems like it would be valuable. And so I'm going to attempt to do that over the next few minutes. So first, what we're trying to achieve here is really a facilitated discussion about research collaborations, experiences, successes, failures, in ensuring sustainability and the local dissemination and impact of research, and to share perspectives on how we can ensure parity and equity in global oncology research collaborations. We will be using this Mentimeter tool throughout this session, and the instructions, the website, and the code that is needed to participate in this dialogue using Menti is shown at the top of this slide. So the Q&A function will also be enabled, and I guess what we're hoping is that people who have specific questions for the panelists can submit those to the Q&A. However, we will be largely orienting this discussion around a series of questions focused on equity that I'll be leading the panel through. We would really invite your contributions to those, to helping to answer some of these critical questions related to equity in global cancer research and control. And if you would like to do that, we'd encourage you to participate using the Menti tool. What that will allow us to do is to collate and synthesize some of the audience responses around these critical questions in real time. And we'll actually try to display that and respond in real time as panelists. So again, I think this is going to be a slightly multimedia experience, which poses, I think, real dangers in real time. But we felt that this, trying to really engage all of you in helping us to think about these difficult problems was critical in achieving the goals of this session. Even though that creates, as I said, a fair amount of anxiety in me as a facilitator. And please do use the Q&A tool for questions to the panelists. Next slide, please. So I think we are all committed to global cancer research. I think in this community, we at the NCI Center for Global Health, our vision is to reduce worldwide cancer suffering through global scientific discovery and dissemination. One of the ways that we hope to do this is by supporting and conducting impactful research that addresses key scientific issues in global cancer control and or leverages unique scientific opportunities afforded by global collaboration. I'm not going to give an extended lecture about our views on equity at the NCI. I will invite you, I'm actually going on Monday at 1 p.m. is the next NCI Board of Scientific Advisors meeting, and I'll be talking quite a lot about our Center for Global Health vision. And Dr. Sharpless in his director remarks will also be talking about the larger equity and inclusion program at the NCI. That's a publicly videocast meeting, which I would invite you all to attend. But really our intent here is to hear from the community rather than offering NCI perspectives on this topic. And it's clear that impact really depends on effectively translating and disseminating research findings, whether that research is successful or not. So what we would like to acknowledge during this session is that there remain significant gaps between science conducted in LMICs, often funded by and involving scientists from high-income countries, and the dissemination and or implementation of findings in LMIC settings. And again, I think a nuanced discussion around that essential problem is what we're hoping to achieve today. Next slide, please. So I continue to work largely as a clinical translational investigator in my scientific portfolio focused on lymphoma or in lymphoid malignancies in low resource settings, having lived and worked almost entirely in sub-Saharan Africa during my academic career before coming to the NCI a year ago. So I often use this example of Burkitt lymphoma just to, I think, try to somewhat simplistically illustrate the set of issues that we're hoping to engage around. So as many of you will be familiar with, Burkitt lymphoma was a new human tumor discovered in Uganda by Dennis Burkitt, an Irish surgeon in 1958. That tumor, of course, bears his name as a European. And I like to often illustrate that, again, these children in Uganda really contributed significantly to the identification of this new human tumor that led to the discovery of a new human oncogenic virus, the Epstein-Barr virus. That led to the discovery of multi-agent chemotherapy as an effective treatment for human cancer, including work done at the NCI in collaboration with Ugandan patients and scientists and clinicians. Subsequently, c-MYC was identified as a human oncogene, which remains largely undruggable. And all of these biologic insights really led to therapeutic optimization over several decades that have resulted in amazingly good outcomes for a broad range of children, adolescents, adults in high-income countries using fairly intensive multi-agent chemotherapy strategies. And what I like to point out is, I think much of this progress has not really been delivered back to children in Uganda, Malawi, other comparable settings. And I say that because during the decade that I lived and worked there, we routinely saw children who presented very similarly to Dennis Burkitt's descriptions in the 1950s and 1960s, and also had very similar outcomes to what was described during that period. And so again, this final missing step in the cascade, which I think we have a moral obligation to address in addition to a scientific obligation to address. Again, to me, these decades of discovery should lead. The natural next step in inquiry is how can we deliver a deployable curative solution back to the very children who initiated this progress. And so again, this is just to simply illustrate some of the issues that I hope we can begin to tackle with today's discussion. Next slide, please. The other thing just to point out, and this is work that Dr. Pramesh has contributed to recently that I have found quite fascinating. The other thing to say is that this inequity between low and high income countries with respect to global cancer research does not reflect disease burden nor scientific value. You know, it would be easy to say, well, LMICs are just underrepresented because they don't have as much cancer or because there aren't really these, you know, scientific opportunities to move the field forward. And I think that is objectively untrue. On the left of this figure, you can see on the left side of figure 1 are the top 10 cancers by mortality. And then on the right side of figure 1 are the top 10 cancers by randomized phase 3 clinical trials in oncology published between 2014 and 2017. And what you can see is that many of the most common cancers, particularly ones that are common in low and middle income countries like liver cancer, cervical cancer, are not at all well represented in the randomized controlled trials that are being conducted by the oncology community. And then in table 2 shown at the right of this figure, you know, only 8% of the RCTs, oncology RCTs conducted during this period were in LMICs. But these studies conducted in LMICs were actually more likely to meet their primary endpoint and to have a statistically significant result. So again, it's not really that this cancer research inequity really, I think, is not reflective of disease burden nor scientific value of the opportunities that present themselves in LMICs. Next slide, please. And of course, this is reflected in the literature as well. So, you know, universally, cancer, even again, despite addressing worldwide disease burden, despite in many respects being more scientifically informative than RCTs conducted in high-income countries, oncology RCTs that are done in LMICs have largely been relegated to relatively low impact journals, and higher impact journals are, you know, exclusively largely for RCTs done in high income countries. Next slide, please. So, you know, I think really moving this forward, and so much of the equity discussion really centers around partnerships and collaboration, and clearly partnerships between researchers in high income countries and in low LMICs can be immensely productive, rewarding, but they're often imbalanced, supporting the careers and priorities of the former rather than the latter. I think this is due to entrenched power asymmetries, often linked to funding sources that can undermine local expertise. Investigators with a track record are often favored for funding. Grantsmanship and grants management capacities are needed even to get a foot in the door, and often these are lacking at LMIC institutions. Academic promotion priorities in high income countries exacerbate these imbalances. You know, we are instructed to publish in high impact journals rather than more local journals that may have more local impact. We're you know, directed by to compete for first and last author status. And of course, there's, you know, often a problematic pose and gaze of publications in general. Next slide, please. And just to end this opening framing, you know, this conversation is obviously occurring in the larger context. And again, I'm confident that all of you are having these same types of discussions in your own institutions and programs, and I think that's a welcome development. But you know, and I think what I'm hoping is that we can draw on this larger context while having a specific conversation about equity as it relates to global cancer research and control. And I think with that, we'll end the slides and try to move on to the discussion. So again, I think we can get our panelists up, and what we're hoping to do is to, we have a series of questions that we're going to try to address as a panel at the same time that we pose these to the audience, and again, would invite contributions using this Mentimeter tool. And as those responses are synthesized and collated, we'll try to, again, display those and also respond as a panel. So I want to open it up, and our first question where I'd like to begin is really just, what does equity mean to you? So what does equity with respect to global cancer research mean to you? And I would like to open this up to the panel. So Dr. Paz Soldan, perhaps we can start with you. And I just want to mention, I don't see Dr. Vanderpooy on my panelist screen, so I don't know if we can bring her up or not. But Dr. Paz Soldan, maybe you could start. It looks like you're on mute.
Sorry. Okay. Yeah, thank you. When thinking of a public health approach and system in global cancer research, I believe that to ensure equity, we need to move health policymakers and Ministry of Health from setting like the best clinical practice, which is individual patient provider interaction for all, but that is often unachievable for all in that country, and to move to what is the best public health practice or policy, which will allow us to prevent the maximum disease in the whole population. And this depends on what we can give all, considering the heterogeneity in a country and the geography and the resource and the health of delivery centers, et cetera. In Peru, which is where I'm based, we have seen a lot of pressure put on the Ministry of Health to set standards that are high for cervical cancer prevention, and that every woman who has a positive HPV test must get a colposcopy follow-up, despite the fact that there is not enough colposcopy equipment nor enough doctors to operate this. And so basically the system fails its women before we even get started. So I believe that to ensure equity, we need to start thinking of, okay, if you have these resources, sure, this is plan A, and this is what you can offer. But if you do not have those resources, do not like leave those local regional health authorities unattended or with no plan B for the reality that they're living with, because that will allow us to focus on developing a system that is equitable to ensure that all individuals have the best and most evidence-based care with what can be offered. And I think that another important element is that a lot of times decision-making is made in the center, in the capitals, where there are the most resources. And if we truly want to be equitable, we need to surface the nuances and the diverse perspectives and issues that are happening in other parts of the country, in more rural, more remote areas that don't have those resources. So I believe that's part of the equity picture.
Yeah, thanks, Dr. Pasaldan. I just want to echo, I mean, I see many of the themes that you alluded to actually populating in Menti, you know, local needs, a focus on local needs, community engagement, fairness. Dr. Van der Poel, I see that we have you up. I wonder what you would like to add in terms of what equity means to you with respect to global cancer research.
I'm very sorry for the hiccup. My internet went off, so I had to change to another office. Yes, when we talk about equity, I think global cancer research might be a little bit skewed to what the high-income countries want to know about cancer in this part of the world, versus trying to solve our problems. That is the impression that it gives. I think that the first thing is to do a needs assessment in the region where you want to conduct your research, to see whether what you want to do is going to impact on that community and probably translate to the rest of the region. I think that we need to look at the dynamics of the health systems. We need to look at cultural aspects, which might be totally different from where you come from. So your views might be totally different from, I think the first thing to do is to try and study where you want to do the research and see which is the best research priority for that region. I know most of the money and the funding comes from high income, and that actually impacts a lot on what kind of research is done. But unfortunately, the South collaboration doesn't seem to really benefit that much. I think sometimes the reason is that we are where you were 30 years ago, unfortunately. So it doesn't make economic sense to research things that are old and you have found an answer to. But then putting that in our perspective might give you a totally different answer and view on what you're trying to research. So I think the needs assessment is correct. We need to prioritize what we want to do. We need to make sure it is translated back into the community and it is cost effective. I think these are things that are missing to me in terms of ensuring equity in both sides. And most importantly, developing the research agenda in these communities, because most of us don't have it, or it's at the rudimentary stage, and we need your help to grow that up. But sometimes the research is skewed to one side and doesn't really translate into, and there's nothing left behind after the research is over. I think for me, this is just my take on it.
Yeah, thank you. I mean, clearly this theme of a mismatch between research priorities and local needs seems to be emerging both in your comments and what we're seeing from the audience. Dr. Pramesh, do you have anything to add or elaborate? Again, I alluded to even some of your work describing this issue.
Thank you, Satish. I think Valerie and Verna have done a great job in summarizing some of their thoughts on equity. And to me, it comes down to a few common themes, which again you are seeing on the visuals as it streams by. We need to look at the quantity, the quality, and the contextuality of the research that's currently being done. And as our recent work showed, the quantity of research being done in low middle income countries is disproportionately low compared to the disease burden. And that's something that we need to look at very seriously. Again, reiterating the point that the emphasis on randomized trials being done world over does not necessarily correlate with the disease burden. And as you can see, there was serious discordance between the cancer mortality seen across the world and the emphasis on randomized trials, with the majority of trials being done in breast, lung, prostate, and colorectal, whereas the burden of disease was very different globally. To be the single most important aspect that we need to look at is the contextuality of research. And here we look at much of the problems, and just as Verna alluded to in her bit just before my coming into this talk, is the fact that very little of the research that is being done in many regional situations is actually relevant to the local situation. So just to give you an example of some work that we did at the Tata Memorial probably 12, 13 years back, we all acknowledge that trastuzumab is a breakthrough drug. It has remarkable benefits in breast cancer. But when we looked at the total number of our patients who were eligible for trastuzumab, by which I mean HER2 positive patients in 2008, we realized that only 8% of those patients were actually getting the drug. And this was a reflection of the exorbitant cost that was associated with it. Come 12 years later, we are in a better position. We are closer to 55% of patients getting the drug. But this has been more because of some very contextually relevant research, in the sense that a shorter course regime, which was shown to be as effective as a longer course regime, which meant that several more patients could afford the drug, is something that we need to look at. So primarily it comes down to implementation science. How do we implement the knowledge that we know now to be actually readily available to the vast majority of the world's population with cancer? To me, that is the crux of where equity in cancer research comes to.
Thanks so much. Dr. Newman, thanks for joining us this morning. I wonder if you had anything to add.
Hi, Satish. So thank you so much for inviting me to be a part of this. It's been a fascinating conversation already, and I am really moved by the focus on discussing the mismatch has been described by you and others between defining research goals in cancer based upon local perceptions in Africa and other low and middle income countries and other low and middle income areas, and the research needs that are defined by the Western world and the academic community. And that's definitely something that we need to address. In my own experience in being involved in breast cancer research, mainly working in different areas in Africa and linking that research to understanding breast cancer disparities here in the United States between African American and white American women, I'm constantly being asked to justify the relevance of this research in terms of the worldwide population, and the importance of studying the breast cancer burden in Africa and in African ancestry individuals seems to be minimized. As an example of that, I can tell you one comment that I received in a review of a grant application that I will never forget was, this was a grant application where I was looking for funding to support the work that we do in Ghana. And one of the reviewers said that there was really no point in our team going to Africa to study African ancestry. I lived in Michigan at the time. They recommended that we simply do this work in Detroit. And that was just, I could not believe that I saw that comment on paper. This work is very relevant to all of us. It is certainly relevant to communities in the different nations of Africa, and we do have an obligation to make sure that it gets done. I do believe that it's worthwhile. Investing in the research capacity of low and middle income countries is good for the local economies. It builds up employee base in terms of technologists, scientists. It builds up total resources in terms of laboratory facilities and laboratory staff. Very, very important in terms of local economy, in addition to meeting the research needs themselves in terms of understanding cancer burden in Africa. It also provides wonderful clinical opportunities in creating partnerships between researchers in Africa and the clinicians. And in the context of developing and implementing these partnerships, it also unmasks really important gaps that we have to fill with regard to clinical service. For example, again, going back to the breast cancer experience, in the context of conducting breast cancer research in partnership with facilities in Africa, we start to understand that much more emphatically the deficiencies of basic pathology supplies to process tissues in most of our partnering hospitals in Africa, the inability to perform immunohistochemistry to characterize breast cancers. And in breast cancer, immunohistochemistry is so very basic in being able to define the most important treatment needs. So these partnerships are critical. They are important globally for everyone, but they are particularly important to the populations of the low and middle income countries, and we should not be minimizing that importance.
Thanks, Dr. Newman. I think that was a really great to hear all of your perspectives. I'm trying to avoid going down the rabbit hole of revisiting misguided comments on my own grants and papers historically that have largely been focused on cancer patients in sub-Saharan Africa, and try to move on to the second question, which I think extends some of the dialogue that we've already been having. So obviously, I think you've all alluded to equity is a big topic. I think we've seen that in the audience responses as well. There are multiple points along which this complex continuum that one could really focus one's attention in trying to achieve equity. One would be community engagement, another would be provider education, another would be clinical care delivery. Maybe Dr. Pramesh, we can start with you as someone who has tried to coordinate, some of these efforts across the National Cancer Grid in India, a complex set of really a complex health systems type endeavor. Is there a particular place where you think energy should be initially focused in trying to achieve this larger goal of equity? Where is the real bottleneck, and where is, what's the lowest hanging fruit perhaps?
Thank you, Sadish. That's a terrific question, and I'll go against the grain when it comes to where the poll shows. I will say that changing clinical delivery guidelines and practices is probably number one. And the reason I say this is because of the realization that what we lack in most parts of the world is not cutting edge science, it's not genomic medicine, it's not precision medicine, it's not robotic surgery. Where we actually lack from is from implementing what we already know. And I think Bill McKillop from the Queen's University actually mentioned it very nicely when he gave his oration at the Tata Memorial very recently, which was in achieving the achievable. It's implementing what we already know in more parts of the world, which will save far more lives than the best cutting edge research. And this is where I think we have failed the most. All of us, the moment we talk about advances in cancer research, start talking about cancer moonshots. No offense meant to any of the moonshots that were mentioned before. But nevertheless, I think the greatest moonshot that we could achieve is actually an earth shot. It's in trying to implement the evidence that we already know. It's the basic drugs, it's the basic surgery, the access to radiotherapy, the access to good palliative care, which is lacking and which is likely to improve the outcomes of patients across the world rather than any of the other areas that we are working on. It's not to trivialize the efforts of innovative science. We've heard of the remarkable advances we've had with CAR T cell therapy, with immunotherapy and so on. but we need to balance the implementability of a new innovation with what we are researching. And there is the biggest gap, and in my mind, the valley of death that we need to cross. And the sooner we realize this, the better it is.
Yeah, those are great comments. I'm going to maybe go to Dr. Paz-Soldan next, who I think approaches this from a very different kind of social science, health systems delivery perspective. You know, are we kind of overly biased as oncologists in thinking that, you know, care delivery and treatment of patients is the right place to go in trying to achieve equity? Are there is there lower hanging and, you know, larger fruit?
Yeah, I thank you for, I have to say that I feel that we can't solve a complex problem by focusing on one element of the system. And so I feel that healthcare is delivered in a complex system, and we need to really focus on all of these systems, all of these elements, see the interrelatedness of these parts. And that's why we need to really start using systems approaches. And I think of medical doctors, when you see a patient and you have a new medication or even an old evidence-based, you know, medication that you know works, you don't just give that medication. You think about like their comorbidities, and you think about like their ability to take this medication every day, or if they have to come into the city and if it's 2 hours away, maybe they won't be able to do this every day. You think of the complexity around that patient. And I think in public health and in really trying to improve public health practice around cancer globally, we need to really be thinking about sustainable and resilient systems. And I think, you know, that means moving away from that one tiny element of the system, one innovation, and support funding and work that leads to the sustainable and resilient health systems. And that needs a systems approach. And I think, you know, we think of complexity as as a key determinant of translation, but it's not a nuisance that we need to control. It's something that's harder to do research on. It requires more perspectives. It requires different study designs, different ways to evaluate. But that complexity is specifically what we are dealing with as we're trying to implement evidence into the field. So I think that in conclusion, my answer is that we can't just focus on one element or one aspect of any of these priorities that was asked about, but that we really need to be thinking about the systems approach, which makes it more complex, but that's what it's like also when you're dealing with patients.
Yeah, those are great points. I think in some ways they're reflected in our Mentimeter poll, which shows a pretty equal distribution across the categories that we've pre-populated. Dr. Newman, did you have anything you wanted to add there about where we should be concentrating our attention with respect to trying to achieve equity?
Yeah. I would only emphasize the importance of increasing the volume of clinical providers and specialists in cancer care delivery in low and middle income countries. It's just so incredibly difficult for patients to get to the providers. There aren't enough.
Dr. van der Puy, I know you have addressed a lot of these issues in various leadership roles in aortic and other regional and international organizations. I wonder, do you have additional comments here about where we should be concentrating our attention? It looks like you're on mute.
Okay. Yeah. Hello. I agree with what the poll says, that equal division among changing the clinical delivery practice. The issue here is when it comes to equity, what you do in the high income is totally different from what we can do where we are. I think Pramesh talked about that. What we don't need is aeropathic surgeries and genomics medicine. No apologies to anybody. But when, like Lisa said, she's found that out by working on the ground here, that even the basic immunohistochemistry, for example, breast cancer, is not being done. So you can't even right now even start talking about anything else. You can't even talk about the new treatments that are available because they're not even, we haven't even begun. A lot of people say we do immunohistochemistry, but they really don't. Systems research, what is going on in these systems? I think these are things that, so educating the providers, which actually includes the Ministry of Health. And that is the beginning for most of us because we don't have that many private institutions. So beginning to educate the providers is the first step. And I guess that got the highest point. I agree with it. Changing clinical delivery guidelines, you can't just change. You need to actually coordinate with us to see what is feasible. It's totally different. What is feasible and what can you change and what can't you change? Because we can't talk about innovative things when we haven't completed what is the basic. We don't even have enough oncologists to take care of the basic. Let people get used to it. Let people see the positive outcomes that are coming from these expanded roles of oncologists in these countries. And then we can start talking about changing guidelines because even the basic things haven't been done yet. When it comes to client-patient engagement, I agree with that 100% because they are the ones who are going to be able to drive the change and make sure that they're getting equitable access to everything else. That's probably what I would say.
Great, thank you all. I think to summarize, I think what I heard was that trying to craft a simple solution to a complex problem is probably not the right answer, and maybe actually exacerbating inequity to try to approach it in that way. So I want to try to move on and maybe try to make it through a few more questions. So I think relatedly, we've started to touch on this, but we wanted to try to start articulating some of the barriers that exist both in local environments and also in high-income countries to achieving the sorts of equity that I think we're all aspiring to. So perhaps we can first focus on the local setting. That meaning the LMIC settings. What do all of you feel are the major local impediments to advancing the translation of research findings in a way that actually benefits people, patients and populations? Dr. Newman, maybe I can start with you.
Hi, thanks. One of the things that I would emphasize here regarding local impediments is I think that we really need to have better, more effective partnerships with industry. I know that my own collaborators in breast cancer work in Africa, in both referring specifically to Ghana and in Ethiopia, they have incredible difficulty getting access to surgical supplies, surgical equipment, pathology supplies, simply because the companies that manufacture these products have all sorts of roadblocks up in terms of getting those products to the hospitals and to the clinicians. So I really think that ineffective partnerships with industry is a huge barrier that we have to overcome. Industry has a role in this effort to achieve global health equity also, and we need to make sure that they and I think many of them want to step up, but I think that we need to guide them to do it effectively.
Dr. van der Pooij, major local impediments in your mind that interfere with the translation of research findings to patients and populations? I'm seeing funding emerging as a dominant theme in the Mentimeter poll as the audience is responding.
I think it really is number one, funding, and it also translates into the health system. And then resource availability is all, rotating around funding, really infrastructure. That's our biggest headache, and it's all something to do with funding as well. So it starts also from the politics again, because unfortunately for most of us, it's the politics that actually drives the strength of our health systems. It's sad to hear that they are not independent of entities, but unfortunately they are kind of like intertwined. So if you have if you don't have a strong political will, it doesn't translate into strong health systems. It doesn't translate into basic infrastructure, not just health, but anything else, because somehow it actually does work together to make this happen. And also, I would say also our we don't have enough education for the providers to see the importance, and we don't see the translation. Maybe we are not privy to these findings in these journals. Let's talk about that. Most of these things are found in high impact journals that are not accessible to us. So we cannot translate these findings that have been found elsewhere to see how we can adapt it to our settings. So it's so many things, but I think I agree with everything there and what the audience said, that unfortunately it is true. Funding is number one, infrastructure, political will, mentorship is missing, training, everything. Unfortunately, it is so difficult here, but I think we still have a way by taking the low-hanging fruit, like you said. I think it's important.
Yeah, thank you. So clearly funding, infrastructure, training, mentorship, I think politics, a lot of these things are really rising to the top.
Yeah.
Dr. Pramesh, you've dealt with a lot of these issues in India. Anything that you'd like to elaborate on?
Thanks, Satish. I think Verna, Dr. Newman, and Valerie have alluded to most of it, but I'll just try and distill it down to probably 3 points which are the most important, at least in our context, which is protected time for research, the lack of training in research methods, and funding. So I think enough has been said about funding, so I'll not dwell too much about that. It's certainly a challenge, especially in situations like ours. But a couple of other important points that we need to actually think about is the lack of training in research methods. In most countries which grapple with this problem, it's a question of the chicken or the egg phenomenon, which is, do we wait for research opportunities to train our young career physicians on research methods, or do we train them and then wait for the funding? And very often this is a difficult situation to address. Most medical schools in India, and there are close to 800 currently, lack training in research methods, both in their undergraduate and in their postgraduate education. And I'm pretty certain that this is similar in most other low middle income countries in the world as well. So as part of the National Cancer Grid, we've been making several efforts to try and bridge this gap, trying to have boot camps and kind of hackathons on how to train people in medical in research methods. But certainly this is something that needs to be scaled up much more than what we are currently capable of. The final point that I want to mention is about protected time. There's a lot of interest, especially in academic institutions and research and clinicians in academic institutions, to do locally and regionally relevant research. But when you're faced with 150 patients in the outpatient clinic, and you need to balance your time between basic patient care and research, I don't think you need many bets on what wins. And this is, to me, a very important point. So often, many of my colleagues who are working at probably, arguably, the biggest, the most academic cancer center in this part of the world, just don't have the time to indulge themselves in research. And most of them do research outside of office hours. And in today's world, when looking at work-life balance is so very important, this is clearly not a healthy situation. I'll end with this example that I very often quote in when it comes to emphasizing the importance of this, which is the fact that the Tata Memorial is sister institutions with the MD Anderson Cancer Center. And just to give you an idea of what kind of patients we see, the MD Anderson sees approximately 42 to 43,000 new patients with cancer annually. We see 46 to 47,000 new patients with cancer annually. The MD Anderson has a total of permanent clinicians and faculty at close to 1,800, and we have 188. So to me, this imbalance, which is 1/10 of the kind of staffing structure that high-income countries have, is the biggest challenge to doing any kind of clinically or contextually relevant research in low-middle-income countries.
Great, thank you. Dr. Paz Soldan, I want to give you a chance to chime in as well.
Sure. You know, yesterday there were several topics that were brought up when we were talking about local impediments, and some of the words that I heard were bureaucracy, lack of data, lack of coordination, fragmentation, challenges to the system like what COVID did. And I will even add, being here in Peru and seeing among my peers, language issues, since a lot of times they can't read the English journals, or they don't master English in a way that they would be able to really understand all of the literature, as well as political instability. And that's not only in Peru, but we've had 4 presidents in 5 years. We've had, 6 cancer coordinators in 5 years. And one thing that I've seen that acts as a local impediment is this lack of a continued vision that goes through time. And so as each new cancer coordinator has come in, they've come in with a different vision and a different way they want guidelines to work. And so guidelines keep changing, and how do you implement that when you need the time for implementation? The other thing that I have seen, at least here in Peru, is that a lot of times when the Ministry of Health works with the experts in the field, These experts are not necessarily up to date with the latest literature. They're not, and they have heavy weight. They're heavyweights, heavy voices in the field, and are often now centered and working in hospitals in Lima, where they have access to certain types of resources that are not available in most of our country. And so as a result, they often set the tone as to what policies are going to be set for the country, what guidelines are going to be used. And yet when these guidelines come to the more rural and remote areas, they find themselves pushing back or struggling because they just know that it just is impossible to carry out. So I feel that where we put, that bringing multiple stakeholders to the table in making these decisions is a way to kind of try to overcome that. And I think as researchers, we focus a lot on what we found and what is wrong. And I think we need to start moving towards asking ourselves, how do we change this and how do we make this better? And I think of that in the equivalent of like with a medical doctor. You don't just stop with a patient when you find the problem. The next thing is you need to figure out how you're going to manage that patient and what is the best approach for that patient. And yet I feel that a lot of times in research, we stop with, we found this problem and we publish it and that's great. And we publish and publish and publish, but it's not necessarily leading to change in the public health practice. And so, but for that, as some of my colleagues beforehand have mentioned, it's also about teaching the research skills. And these research skills are not only about how to do a randomized controlled trial or how to study one element of a system. We also need to be teaching our colleagues, our researchers, that are coming up in the system, how to deal with this complexity in the system and how to do implementation science. And so we need to fund this kind of work, and it might be slower. It doesn't lead to as many papers. But at the same time, it allows us to have a truer and lasting change in the system. But that's a lot of things. But
thanks. I actually want to follow up on that a little bit because I heard Dr. Pramesh and Dr. Pasaldan and Dr. Vanderpoel all allude to this, the kind of politics and ministry and leadership and the need to support young talent. This was actually a note that I had made to myself as something I was interested in preparing for this morning session. I think one of the tragic kind of legacies of colonialism is these internal power structures that it left behind within colonized countries as vestiges of colonialism. I often found kind of org charts for institutions are intensely pyramidal, and there's often kind of hoarding of expertise and resources at the top of the pyramid. And I think sometimes you have truly visionary, effective leaders who are really serving the best interests of their, stakeholders and their communities. And sometimes, I think as you all have alluded to, you don't have that. And that's a really difficult problem to know, particularly how to influence as an outsider. And, I think I ended up feeling that really supporting new young talent seemed like the best way to address that and move towards a more future kind of oriented model. But I would love to just hear you elaborate on some of those issues. How again, if we'll get to high income country barriers in a second, which I think are many. But I wonder if you have more insights into how to address, I think these fairly difficult power dynamics within the low and middle income countries often. Dr. Pasaldan, I see you raising your hand. So,
well, when we first started our project, we met with local stakeholders in the region where we were going to be working at, and one of the first comments that came out of somebody's mouth was, "Just give us the stuff and we'll make it happen. We'll make it happen." And the other comment that came out of the same person was like, "Oh, it's another project that's going to come, do their stuff, and then when they leave, we have to go back to what we always did." So there was already this perception that groups come in. Sometimes they're charitable groups, sometimes they're research groups, sometimes but they come in, do their thing, funding ends, and everybody goes back to the same because there wasn't there was not an effort or push to make a sustained change in the system or to help. And so I believe one of the things in response to your question, how do we make this happen? I do believe that true collaborative partnerships, where we partner academic institutions with local authorities, local academic partners, local leaders, so that they gain the skills of how to make this happen. And we have seen, at least in Peru, that some of the people that we've been working with closely, we've been taking a step back in terms of how we participate and letting them take the leadership. But, one of the people who was working with us was also the malaria coordinator for the country. And at one point she says, oh, I'm going to be using the same way of thinking about this and do it for malaria. And so you see that like just teaching some of the skills to making this happen. When I've worked with the Ministry of Health and talking about like implementation plan, they're now going to be scaling up some of the work that we've been doing. They're going to be scaling up in different parts of the country. And I say, do you have an implementation plan? And the implementation plan, I'm not trying to, but it looks like a timeline with a few trainings. And that's not an implementation plan. So I think part of the work that we can do I feel can be facilitated with real partnerships, with real respect, with real collaboration, where we start working with local partners to develop the skills to develop these types of plans that are more detailed and incorporate all the different elements.
Thanks. I want to give Dr. van der Puy and Dr. Pramesh a chance to respond here as well. And then maybe we'll have Dr. Newman kind of lead the discussion about high income country barriers. Both of Dr. van der Puy, you and Dr. Pramesh, I think, in some ways sit at the top of pyramids and have been visionary leaders for your respective organizations. So I'd love to hear your perspectives on, how to ensure that kind of power structures within the LMIC institutions and organizations can really serve their young talent and their populations optimally.
I think it's quite difficult because unfortunately we are driven by the political scenario, which unfortunately changes quite fast. But I think we still have development partners that can actually help to institute the fact that some of these organizations should stand independent, so that most of the work is carried through and not switched around depending on the political climate. And I think most of these collaborations and whatnot should have include dissemination and implementation, whether including dissemination of negative findings. I think that's quite important. I think we should partner with local journals or media to make sure that this information is gotten out. Luckily, there's a lot of high penetration of the internet. So I think this becomes more available to other people to use. And then importantly, like you said, we need to start training the next hierarchy of research groups. So the young people, but they just don't seem to have a lot of leverage, because I think just because the way of our systems, we are busy with other development issues. We tend to forget about mentorship and about training the young upcoming physicians or researchers in our groups. And I think this is missing. And I think when we get the opportunity, it's also something to really talk about and push them to the forefront. We tend to concentrate a lot on these old experts, like somebody said, who are very narrow-minded. But I think these young ones with exposure to a lot more, they're able to help to make these things happen. I think it's something that we need to really do to make sure that this happens. It's difficult for each region, but for me, it's very, very difficult. I'm sure Lisa will say something about that because she has penetrated through the system.
Dr. Pramesh, anything to add?
Very little, but coming back to the 3 points that we mentioned, which was the lack of protected time, the lack of training and research methods, and the lack of funding. So I think it's for each of these, it requires a totally different approach. For funding, it comes back to advocacy and ensuring that we promote the importance of clinical research, especially in cancer, when it comes to funding research. So to be honest, I don't think in a country like India, we lack for funding. It's just that most of the funding is directed towards basic and fundamental science and not enough towards clinical and implementation science. And therein lies the biggest problem. We've gone the way of the West in trying to fund a lot of basic and fundamental research. It's again not to suggest that basic research or fundamental research is not important. It's just that there needs to be a rational way of apportioning the scarce money that you have for research funding equally or equitably between these various aspects. Coming to training and research methods, it's something that is more easily fixable. We had demonstration projects within the National Cancer Grid to see how this could be replicated at a fraction of the cost that training and research methods would have in high-income countries. And this is something that we expect and hope to replicate in several other low-middle-income countries in the world. The toughest problem again comes back to the lack of protected time, and this is not an easy problem to solve, primarily because if you had to actually prioritize between patient care and research, most often patient care takes precedence, and this is the only way you could actually address the solution is to increase the pool of clinicians and clinician researchers who could potentially solve this problem.
Thank you all. So I think we've had a really rich discussion around some of the barriers towards achieving equity in the LMIC context. And I want to shift now and maybe talk about the high income country context. So, and the question is, how can high income country collaborators ensure parity and equity in global oncology research collaborations? Dr. Newman, I wonder if you could offer some perspectives and get us started there.
Thanks. Yeah, this is a very important topic that you raise here. One thing that I think is really critical, and it's tough to make it into a concrete recommendation, but it is so very important, is the role of creating partnerships that are meaningful on a personal basis. And this is where the model in Western countries is different from what is necessary, I think, for these global relationships. You know, we're so accustomed in developing grant applications that, you know, you have to have a specific aim, there has to be a goal that you're starting with, and you achieve that goal and the project is done. When we talk about global partnerships, especially between higher income country and low and middle income countries, you really need to have meaningful personal relationships between the teams that are involved in order to have sustained capacity building and sustained durable progress and meaningful results that are meaningful for all of the partners. So the friendships, the true personal relationships that develop, I think, are really critical, and the value of these personal relationships can't be underestimated in making sure that the partnership is successful and yields meaningful results. And this also leads into what's been said previously by Werner with regard to investing in the younger generation and mentorship. You need these personal relationships in order to ensure that we are mentoring the younger people properly and making sure that the young generation of investigators have the guidance that they need, and we enable them to be successful. We also need to be creative in higher income countries when we are looking at the design of budgets for these types of partnerships. I do firmly believe that when we are developing and obtaining grant support for global partnerships in cancer research, that, you know, our partners in low and middle income countries always have to be included as discrete line items in terms of financial support. Absolutely, that is just no doubt about it. But we have to be creative in the way that we allow them to use their funds. We, in the low and income countries side of the partnership, can't be the ones to define the way that the funds should be disseminated. Our local partners know how to utilize their funds better than we do. So we do need to make sure that there is a way to be flexible in the way that those funds are utilized, and how the documentation of the utilization of those funds is going to be different compared to what we're accustomed to in terms of documenting salary support and percent effort in high income countries and academic facilities. So those are the comments that I would make in terms of differences in the way that we look at things in high income countries and the way that these cancer research programs are actually implemented with our low and middle income country partners.
Thanks, Dr. Newman. I'm seeing a lot of comments about bilaterality and listening and training kind of populate the Menti, I think echoing some of what you said. So I think what we're striving for is a model that isn't, you know, I'm submitting this grant tomorrow and would love to include you as a collaborator. Would you mind signing this letter of support? Which I think we have to acknowledge happens much more frequently than any of us would like. Dr. van der Pooij, do you want to add anything there about, you've spoken a lot about LMIC barriers. What do you think the high income country partners can do better?
I think they need to do a needs assessment. I think that's the first thing they need to do, to see whether what they want to implement or whatever research they want to do translates into effectiveness in that health system. I think that really is missing. Or which part of it, it doesn't have to be the whole project, but some part of it might be of interest to us, or something that we need to adopt to improve. It shouldn't always be, there should be some kind of like reverse innovation or something that will work for us. I think it's something that is very important in terms of the funding. And I think they need to make sure that we have equal participation, more than just a kind of like parasitic kind of relationship. So it's not about just doing the genomic studies for use in the United States, but what do we get out of it in terms of what they find out? I think that is very important. What do they leave with us? I know they can leave the technique with us, but if we can't afford the reagents, really, it doesn't really translate into anything. So they need to leverage with us halfway. It might not be the whole project, like I said, but at least we'll take home something and maybe promote our future research. And I think in terms of, I see a lot of problems with the high income publications that come up of these collaborations. You hardly have the participating country being first 1, 2, 3 authors, or even the senior author. And a lot of people are actually losing steam with that. They are not even asked to participate in even the write-up. They are asked to acknowledge the paper or just to edit. And most of the time, you so demoralized that it's difficult to do that. And I think so when it comes to research outputs like publications, I think they need to really sit down and make sure that it's an equal partnership, because we all want to advance our career. Thank you.
Thanks, Dr. Vanderpooy. Dr. Pramesh, do you have advice for high income country collaborators about how they can help achieve equity in these collaborations?
Thanks, Satish. I think previous speakers have alluded to this, but to me, the most important factor is to look at loco-regionally relevant research questions. And this is where I think we fail the most. Rather than look for a nail to hammer just because you have a hammer, what I would suggest is that you look at solutions, at questions which are relevant locally, and then try to address them. Very often we find high-income country collaborators coming in with a problem that they want to solve without actually encouraging the local investigators to look at understanding whether this is a real problem that needs to be solved rather than the other way around. And we've been very, very fortunate that we've collaborated with some phenomenal researchers from high-income countries. But I do know that this is the exception rather than the rule. And often we find something very akin to what Verna just mentioned, the phenomenon of parachute research. And to me, this destroys the entire culture of collaboration that we set out to achieve by way of this North-South collaboration. The second point that I want to mention about is that there should probably be no research without local capacity building. Again, as Verna mentioned, it's great to learn techniques. If it is not relevant or important to the regional situation, I don't think we've really achieved much. So every research project that we embark upon should have some level of local capacity building built into it, without which you probably are not really serving the local population much. And I think it comes back to a typical parental mistake that we do, which is living your own lives and your aspirations through your children. And here I would look at the parent as the high-income country and the children as the low-income country. And that's a trap, parent trap, that we shouldn't fall into, and have a more equal relationship, which looks at important questions locally and then trying to address them with solutions which are equally easily implementable. So you might have a fancy immunotherapy solution or a precision medicine solution to a complex cancer problem, but if it is not implementable, I don't think that really serving very much.
Dr. Paz-Soldan, anything to add there? Best practices for high-income country collaborators. I think you're on mute.
I will make some clear points. One, and this one has been mentioned, building true collaborative partnerships between academic and government institutions to ensure sustainable research and the building of capacity. Fund research that moves us from here is what I found and here's what needs to be done to how do we make this happen so that it happens. Fund that slow, tedious, methodical process of implementing change and that requires that we understand the complexity of the system. And this is where your low LMICs and low-income country collaborators can really help with understanding the context and building that bridge between what we know and what will be acceptable and feasible within that local reality. And instead of thinking that that's something that needs to be hidden away, it's something that really can be surfaced. And I remember a quote that one person said in a global health workshop one time, which was, with your foreign collaborators, we may talk with an accent, but we don't think with an accent. And I think that one of the errors that I have seen with a lot of, in my experience, sometimes the high-income country partner comes with the idea that they think better, even though they don't think about the fact that this person is speaking a second language to be able to communicate with you. So I think the importance of recognizing that everyone has a contribution to make, particularly when you're working in a site where the context is so important to understand.
Yeah, no, I think those are all great comments. One thing I just want to highlight, I think you and Dr. Pramesh both kind of alluded to this, is I think one serious transgression can really undermine an important, decades of work together. And I think that's an important, comment, about, or thing, certainly for the high income country collaborators to be mindful of that, it certainly is possible to really jeopardize a lot of important work, that, collaborative work that's being done together by not addressing this substantively. I did also want to ask one kind of follow-up question. I participated earlier in this week in a larger global health equity themed conversation at the CUGH meeting. And one of the topics that was raised was the need for kind of essentially reparations or wealth transfer. And I sort of alluded to this in my opening remarks. I think it is probably true that cancer research progress, even in high income countries, has often really relied on scientific resources and intellectual capacity from LMICs. And does that, I think funding has come up repeatedly, but is that addressable without, kind of radically restructuring the way in which some of this work is funded, and that could take a variety of mechanisms, right? The way indirects are handled, all of these things at both the institutional and the funder level could really address what in essence would be a wealth transfer or reparations to kind of deal with the legacy, kind of some of these problematic legacies. Or, would such an approach really amount to more aid? And, aid itself has I think a fairly checkered past. So, I'm curious to hear what you all might say about that, just because it's come up in other conversations recently. Maybe Dr. van der Pooij, we can start with you. Do you have thoughts on a need for wealth transfer or reparations as a means of rectifying some of these inequities?
Wealth transfer reparations. I think so. The problem is I'm not sure how we are going to do that, though. I think it will probably solve a lot, because it will ensure some parity in how much we contribute side by side between high income and low income, but I really don't know how we're going to do that.
Anyone else have thoughts or comments on this? I did want to raise it because I think it's an interesting, Dr. Paz-Soldan.
Yeah, I know that the Fogarty Fellowship programs for students who go overseas and researchers who go from one country to another, they're really trying to invest more on working to prepare trainees and fellows on the decolonizing aspects of thinking about the history of colonization and how this affects like the work they may do and the way they interact with others, and also improve ethics. So far, I think a lot of training to these fellows has focused on these one-off events whereas there's an increasing recognition that we really need to be working with junior investigators who get started in work, in global work, to have more of an accompaniment or I don't know if that's a work in English, but to have more support throughout the process of you know, being in a new country, in a new setting, working with collaborators and understanding their role and the other role and not minimizing one. So I think it's thinking about the ethics, thinking about the perspectives, and thinking about how to broaden, you know, their understanding of history and issues that need to be surfaced earlier in their training to get them started.
Dr. Newman, anything you want to add there?
I'm sorry, did you say me?
Yes.
Okay, sorry. Actually, I echo the comments that have already been made, but I did want to comment on something that was mentioned in the Q&A box here, because I think this is important also in the distinction between resources of the high-income country partners in global collaborations. Somebody asked about the role of health information systems, electronic systems versus paper-based, and the transitioning to electronic medical records and how this will impact on global collaborations. And I think this is a key challenge that we do need to address. I don't know the right answer to it, but I think that it is an important discussion that we need to generate.
Dr. Pramesh, did you want to say anything further on this topic?
Nothing much to add except that while wealth transfer is very attractive conceptually, I think the countries need to look at themselves and try and prioritize the importance of clinical research and start funding it themselves rather than look at high-income countries as a potential source of funding their research. So I don't think we, in the longer term, that's going to be a sustainable solution.
Great. Thank you all. So I'm going to move on, and I'm going to perhaps skip to the to question what we'd initially posed as question number 6 about what does successful translation of research look like. I think we've talked a lot about what we're striving for, what some of the barriers are, both on the LMIC side and on the high-income country side. I wonder if we could speak for several minutes about models of really, really models that we should be aspiring toward that may perhaps already exist. And then we may, after that discussion, we may, I think Dr. Newman already did this. There are a few questions in the Q&A that we may try to address before closing out. So the question is, what does successful translation of research look like? Do you have examples where research has really resulted in meaningful and tangible outcomes? And then what created the conditions for these successes? Dr. Paz-Soldan, maybe we can start with you.
Sure. For the past 5 years, I have been working with Dr. Patty Gravett on an implementation science project that moved cervical cancer early detection and treatment in a rainforest region of Peru. So very difficult transportation and a lot of different issues. From screening with visual inspection with acetic acid to direct treatment, and then bypassing an entire step of the care pathway. That's what we moved to. Our work was slow because we ensured that we engaged all the perspectives in the system. We surfaced these multiple perspectives about the bottlenecks and the problems in the system. And we worked through various scenarios with and alternatives with these alternatives based on evidence-based programs with these key stakeholders. And then they decided on the path forward and agreed on a path forward. And so the stakeholders were engaged in developing that path, owning that path, and committing to that path. And because of a lack of a cervical cancer registry or a cancer registry overall, we also set up a monitoring and evaluation system. And within 6 months, the facilities, and we had a scaled up approach, facilities were surpassing their monthly goals that had been established. And a significantly higher amount of women were reaching their care endpoint within 30 days. And during the pandemic, everything went back to zero. And then after the pandemic, everything came back up without our support. I mean, the system picked right up where it had left off, which was to us a very good indication of sustainability, that the system had absorbed this. And I think that there were a few things that were really important in making this a successful translation. One was that there was engagement from all levels in the system. We went from talking to women and engaging women in focus groups and surveys to really working with the highest health authorities, not only at the regional level, but even with the Ministry of Health. And we used a systems thinking approach to address this complex system. I feel that the ownership of the program was made by those local health authorities, and they learned the skills to make this happen. And in fact, at one point, the National Cancer Coordinator changed. He was one of these old dinosaurs with old visions and not up to date with a research, but he came to the region and pushed to go back to pap smears, HPV, forget HPV, pap smears are just as good, we're doing fine. Like, and the community, the local professionals really pushed back on him and said, you know, like, this works for us. This is working for us. This is what we want to do. But they also were empowered. They knew the literature, because during some of the workshops that we've been doing with them, we shared the latest literature, we shared the latest evidence. And so they were able to push back intelligently because they knew the latest information. And so, you know, we adopted this, you know, if you want to go fast, go alone. But if you want to go far, go together, because it's been a slower process, but I feel that that has been a key. And I think another thing, and I would relate it to medical practice, when you're managing a patient, you know, in medical practice, you have these tumor boards where you get specialists of different fields to talk about a patient. Often the patient is not there, but, you know, to talk about the patient and think of the management of that patient from so many different perspectives. And I think that we can learn from that approach in public health to say, you know, one of the things that we felt was very helpful in our process was that we did engage all these different perspectives, and we made sure that all of these perspectives were evident to everyone, that everyone was part of the system, that everyone had to make this happen, and that it wasn't going to work if we only listened to the radiologist. We really needed all the perspectives to be surfaced and clear to all. And I think, you know, that really gave it ownership and engagement.
Thanks. I'm seeing communication, advocacy, engagement, you know, participatory, a lot of these same themes being echoed in what the audience has responded with. Dr. Newman, examples of success and perhaps some comments on what you think created the conditions for those successes?
Thanks, Satish. Well, in my own experience, I've had the honor of collaborating with wonderful breast cancer partners in Ghana, in Kumasi, Ghana, and also in Addis Ababa, Ethiopia. And our partnerships have been extremely gratifying from the perspective of being able to capacity build and invest in technology services, such as through education training and sharing of supplies and resources, being able to develop immunohistochemistry pathology services with our partners, and also being able to invest in the development of core needle biopsy programs. So the needle biopsy programs improve the efficiencies of breast cancer diagnoses in our partnering facilities, and the immunohistochemistry improves the ability to treat patients better and more effectively for their breast cancers. So while we've been gratified by our successes in these areas, it's also been extremely frustrating to see that you can make get these achievements underway, but you see so much more that could be done if the resources were better and more robustly supported. Hence my comments earlier about the difficulties of simply getting supplies to our colleagues in a timely fashion and getting them to our colleagues in an affordable way. We continue to have to serve as liaisons to get supplies for some of these basic services to our colleagues because they are unable to purchase them themselves and get them in a timely fashion and be able to purchase them at affordable rates. So there's so much more that we can achieve, I believe, if we have better partnerships with industry.
Thanks. Dr. Vanderpoel, I want to give you a chance to offer examples of success and perhaps comments on what the conditions that created those successes were.
I'll go back to the to this visual inspection with acetic acid for cervical cancer. So in as much as the findings came out with a cheaper option for screening patients for cervical cancer. So we upgraded to the use of DNA in addition testing, but we realized that there still wasn't a big uptake, not only in Ghana, but most of, I'll talk about Africa for now. And there were, and even some parts of Latin America, and they introduced self-collection for samples because there was a big cultural gap. So like I said, we just come up with research without thinking about the culture, without thinking about the uptake. And that actually increased the uptake of screening in certain parts of the region, because there was a cultural barrier to screening these women. And this was overcome by including self-sampling. I'd also play the devil's advocate with her two new testing for breast cancer. And somehow that research was disseminated everywhere. Everybody saw the big improvement in patient outcome for those who test positive for HER2 positive. But I think most of the implementation was also from the fact that the drug company was going to benefit from this drug. So in as much as we have a lot of biostimulants, we still haven't really done that much. And the company, I think most of the spread of the dissemination was benefit from the company. In as much as we push for 1 year of Herceptin, there is new data showing that 6 months or shorter is equivalent, but nobody's listening to this. So this research is not being disseminated, it's not being implemented. So I think these are things that we really have to look at. So the conditions for translation actually has to fit into that health system as well. It's not just dissemination, but which part of it can fit into that health system. I think that's something to look at.
Thanks so much, Dr. Pramesh. I want to give you a chance to respond as well.
Thank you, Satish. I'm sorry to go back onto this recurring theme of breast and cervical cancer research, but that's the only example I have. So sometime in the late 90s, the Indian Council of Medical Research looked at how we could address the problem of low survival with in common cancers in India. And while they identified that one of the most important reasons was the late stage of presentation, conventional solutions like mammography and pap smear or HPV DNA were not implementable. In fact, they actually did a study in which they figured out that even if you were to multiply the total number of pap smear and to their lifetime. So clearly that wasn't the solution that we got. When at that time the insurmountable problem, and low cost, low tech solutions for screening for these two common cancers, which between them account for 55% of all cancers among women in India. So we wanted to evaluate the effect of visual inspection with acetic acid and clinical breast examination as strategies to screen and detect early cervical and breast cancer respectively. And to this day,
it looks like I have lost Dr. Pramesh. I think hopefully he will come back on. So we'll move on then, just in the interest of time. So I think we have about 12 minutes left or so. So, my anxiety about leading a 90-minute conversation on this topic obviously was unfounded. We probably needed 90 hours. I would like to try to get to a couple of questions that have been posed, I think, in the chat box and the Q&A, which I think we have maybe very superficially touched on, but I think really are on topics that we haven't addressed substantively. So I'm going to try to pick out two of these questions, and I think that will probably take us to the end of our time, and we'll have to sign off and provide a little bit of a break before the Perlin Awards. But the first question, which I think is both in the Q&A and in the chat box, is really about publishing. The need for open access publishing so that science is rapidly available to everyone, and that we can ensure that science is adequately transparent and reproducible, in addition to it supporting equity. Maybe Dr. Pramesh, I'll come back to you just to see if your audio is okay, but I know within India, many, I think the Indian scientific community has tried to leverage, its might, its impressive might to try to address some of this with scientific publishers recently. I wonder if you could talk about efforts to secure open access publishing as one tool for achieving scientific equity.
Thank you, Sadish. I think in theory, this is a great approach and something that we should certainly aspire for. And the government of India is currently looking at negotiating with publishers on providing open access publication without processing charges to its researchers. It's still work in progress. We haven't yet got a clear signal on this, but this is certainly something that we could look forward to. But in the absence of this, while extremely attractive, it offers the opportunity for access research without having beyond paywalls. Very often, the reality is that the article processing fees are expensive, and most researchers in low-middle income countries find it out of their reach. And there are, in fact, examples of how much article processing fees have been more than the actual budget of the research itself done. So this is not a small or a trivial problem to address. So currently, a typical article processing fee would be between $5,000 to $10,000, and most low-middle income country researchers, this is completely out of reach. So the solution that we ultimately end up with is to build this into the budget of the project itself, try and get funding for it, and actually increase the threshold for finding funding for these research, which is actually a fairly formidable task, as you heard earlier on in this session. So while in theory it's great, I think it's something that we need to look at the implementation before we consider it a success.
Yeah, thanks, Dr. Pramesh. I think you alluded to publication charges that often could support key personnel for several months in many of these countries. Dr. Pasoldan, any comments on the need for open access publishing?
No, I
what do I want?
Dr. Vanderpoy, we're hearing you. I don't see you. Are you back on? Dr. Pasoldan, please go ahead.
No, I fully agree with what you say. Up to about 10 years ago, I used to get emails sometimes from librarians in Brazil and Chile, et cetera, asking me to send them some of my articles so that they would have them in file because they couldn't afford to pay them. And now what I've seen is that our National Science and Technology, CUGH here in Peru, but I don't know how, but National Science Technology groups are beginning to offer access to some of these journals so that their scientists can afford that $30 article that is, behind a paywall. So I think that is improved, but in terms of actually getting published, it's the same issue as Dr. Pramesh just brought up. And so junior researchers who are trying to, who have a budget of $10,000 cannot afford to spend the $2,500 on open access. And that's what's going to be able to be given the higher index, get more cited if their article is hidden away they can't. So the other thing I was just wondering about is about the possibility that these CONCITEC would help to fund some of these articles, that they might have a way to get the best quality ones and ensure, but I'm not sure how to make that happen, but I definitely think it's a problem.
Great. In the interest of time, there's a couple other questions that I think would be nice to get to, so I'm going to try to do that. One question that I see in the Q&A is focused on the need to use real-world data, to support clinical research. This idea that we should learn from every patient that we see. What do you think the potential is there? Maybe Dr. Vanderpoy, we can start with you. How feasible is that as a strategy for increasing research equity in sub-Saharan Africa specifically?
I would say that we can learn a lot, but the issue is that can only happen if there's equity in the power play in how the research should go, because without that, then we can't really make this a learning curve. I'm not sure most collaborations are there to learn, but I think that it's something that should be prioritized, because this whatever they learn from these trials could actually be implemented in future studies, future collaborations, and also may help in translating the research back into the society. That's what I think.
Dr. Newman, maybe I'll come to you as well. And the programs that you have participated in, what do you think the opportunities are for real world data to drive clinical research and help achieve, more equitable collaboration?
I certainly agree with what's been said already. These partnerships in research between clinicians and most importantly in delivering care to patients, they are incredibly important and powerful. There are opportunities to learn from every patient, not only in terms of tissue acquisition and tumor biology and those types of studies, but learning from our patients in terms of their experiences, where they live, how they are able to get through cancer treatment given their circumstances and local environments. Tremendous lessons to be learned.
And I think this comes back to a question that you had called out earlier, which is you have to have data systems in place that really facilitate this, right? And that's, a tremendous advantage for young investigators working in high income countries is you have a lot of routinely captured data that you can use without a lot of funding, often without a lot of time to really initiate a research career. And I think those opportunities often are not available to LMIC young investigators, and we need to make them available. Dr. Pramesh, is that a raised finger?
It was. So, I do agree that real world evidence is a reasonable way of doing some form of research in the absence of anything else. But I would add a word of caution here that real world evidence is not necessarily practice changing, nor is it practice defining. And that is there true for a reason. Much of the biases that we see in trials which are not randomized are part of the problems that we face with real world evidence. And rather than go that path, real world evidence is terrific for looking at implementation science. But if we had to look at practice defining or practice changing or meaningful, impactful treatment decisions, I don't think we can get away from randomized trials currently. I would flip the problem across and suggest that pragmatic randomized clinical trials are the way to go. And there can be no better example for this rather than what we've seen with the COVID pandemic. Let's take a couple of the research issues that we've had with COVID. The first was with therapeutic options with COVID, and the second is vaccines with COVID. If you look at therapeutic options, probably the single most impactful trial that we've had globally has been the recovery trial. And that's a pragmatic design where most people with COVID were included into the trial, very few exclusion criteria, eligibility was very broad. And we've come up with something like 14,000 patients being randomized in less than a year, which is remarkable by any standards. And if you look at any intervention that is now proven to be useful in COVID, it's thanks to results from the recovery trial. Contrast this with the trials that we've done on vaccines, not to trivialize the effort that's gone into vaccine development and production and proving that it works. It's been remarkable. But if you look at the questions that we have now, are vaccines safe in pregnant women? Are vaccines safe in people with cancer? Do we have the answers? We don't. And that's primarily because typical industry-funded trials are so restrictive in their eligibility criteria that they don't apply to the vast majority of the patients that we see in a clinic. And this is where I think pragmatic randomized trials are the way to go rather than depend entirely on real-world evidence.
Thanks for that comment. I completely agree. I will note that the recovery, that pragmatic trial design does rely on having a system in which one can conduct those sorts of studies, and principally the NHS in the case of the recovery trial. So again, I think these are not mutually exclusive, right? They're complementary approaches that can be synergized with each other, and perhaps perpetuating these false dichotomies is actually one major way in which we undermine equity in global cancer research and control collaborations. So it's 9:39. I think we probably have to leave it there. I want to thank our amazing panel for a really stimulating discussion. I was really hoping to get out of this some perspectives from all of you, as well as from our community, that can really help drive a lot of the things that we're thinking about at the NCI Center for Global Health going forward. And I feel like, certainly I feel like you've given us a lot to think about. Any final comments from any of you? Dr. Newman?
Thank you very much for allowing me to be a part of this. Such an honor.
Dr. Pramesh, any final words?
Thank you, Sadish. It's been a fascinating session, and I've learned so many new things from my fellow panelists and yourself. It's been a truly fascinating session, and I think getting these conversations going is so very important to work towards equity in cancer research and global research for that matter. And thank you for the opportunity.
Dr. Van der Pooij, any final comments? I don't see your video, but. Dr. Pasoldan, any final remarks?
Well, it was very fun to participate in this panel. I've learned a lot, and I must say that one of the things about preparing for today was thinking about, you know, when we think of medical treatment, we think of patient-centered care, and I think when we think of public health, we need to be thinking of systems-centered care. And I think as I was preparing for today, I was thinking, what are the parallels in the two worlds? And but I agree, we can't dichotomize. We really need to figure out what works best and what questions need to be asked.
And Dr. Van der Pooij is saying in the chat that her internet is unstable. So, you know, please join me in thanking her for her participation. So thanks, everyone. I believe we have a 10-minute break until 9:50 when the Perlin award session will commence. So please rejoin us for that promptly at 9:50. During the interval, the scientific poster sessions, I think, will be available for viewing. And again, thanks everyone for a really enlightening discussion. I think we've learned a lot, certainly at the NCI, that will inform our programs going forward. See you soon.
This is Franklin Huang, and I'll be chairing the next session. I'm an assistant professor at UCSF, where I'm a medical oncologist and run a cancer research lab focused on cancer genomics and prostate cancer in men of African ancestry. Along with my colleague, Dr. Ami Bhatt at Stanford University, I'm one of the co-founders of the nonprofit Global Oncology, a volunteer-driven organization based in the Bay Area that works to improve cancer care in underserved patients around the world. Since 2013, we have worked to support trainees and projects in this emerging field. And most recently, we've been working with partners in Belize to establish care for cancer patients and working with partners in Nigeria to launch the Cervical Cancer-Free Nigeria campaign. I am deeply honored and privileged today to present the annual Rachel Perlin Humanitarian Award on behalf of the symposium organizers. Today, we will honor and award two incredible individuals, Dr. Frederick Chute-Asira, the 2020 award winner, and Dr. Carla Alfaro, the 2021 winner, who will receive their awards virtually and then give their keynote speeches, followed by a question and answer session today. Today, we'll be presenting both the 2020 and 2021 awards due to the disruption of the pandemic of last year's symposium. The Rachel Perlin Award honors Dr. Rachel Perlin, who received the award named in her memory in 2016, following her death at the age of 38 in November 2015 from gastric cancer. While in medical school, Dr. Perlin completed rotations in South Africa, Haiti, Romania, and rural China, where she learned to speak Mandarin fluently. For her work, she received a prestigious Fogarty International Clinical Research Fellowship and Tulane's Award for Outstanding International Relationships. Dr. Perlin viewed the practice of medicine as a privilege, always striving to serve her patients better. As part of the symposium each year, we recognize one outstanding professional for their excellence in global cancer research and practice focused in low and middle income countries. The steering committee invites nominations of individuals at any stage in their career who have made major contributions to global cancer research and practice. The nominees' work should focus on cancer research and practice in low and middle income countries. I knew Rachel for most of my life, as she and I literally grew up together on the same street in St. Louis, Missouri. Rachel graduated from Brown University, Tulane Medical School, and finished her medical training in New York, and then her oncology fellowship at UCSF, where in the midst of that training was diagnosed with stomach cancer. She was a marathon runner, a swimmer, deeply rooted to her family, her sister Sarah and father Don, who have joined us for today virtually, and her friends and community. Sarah shared some of her photos from Rachel's travels, which I've just displayed a few of here today to demonstrate how much she had traveled the world and worked with others in the global community. Rachel also lost her mother to cancer at a young age, and so was affected very early by cancer and knew it very well. As a young oncologist, Rachel made an indelible mark on her community, her colleagues, and her patients. She had an irrepressible spirit, was deeply committed to global health and the care of the underserved. She made an impression to everyone who was lucky enough to meet her, work with her, or call her a friend, and she made friends around the world. Rachel had an optimistic perspective that through a magical quality about her made you optimistic and cheery too. She had an ability to make people feel better and gave generously of her time and her friendship. This is why medicine and oncology was the perfect career for her and was reflected in the care she provided for her patients. It has been 5 years since Rachel died from stomach cancer, and still the loss feels raw. She left this world wanting to do much more for her cancer patients and for global health. Even as she underwent treatment for her cancer, she recognized the tremendous privilege that she had access to in her caregivers at UCSF and in this country. She noted that she got to see how truly loved she was before she died, writing during that time, quote, "I really am a most fortunate girl," end quote. Every year that we honor her memory with this award, and her memory is a blessing, I know that her spirit carries on and the work that she cared so deeply about is honored by this event and by the people who have been recognized with this award. I know that she would have been here at this incredible meeting, listening to that incredible panel session that we just heard, advocating for this research and for global cancer equity with every pound of energy she had. On behalf of the symposium's organizers, it is my honor to present the 2020 Rachel Perlin Award to Dr. Frederick Chite Asira. Dr. Chite has dedicated his career to the improvement of cancer in LMICs and his extensive oncology research experience in Kenya and sub-Saharan Africa. A quote from his nomination, "Professor Chite is patient-focused and managed to start an oncology center with very minimal resources and grew the center into one of the cancer hubs in Western Kenya. He is currently spearheading the management of breast, cervical cancer, lung cancer, and Burkitt's lymphoma in the region through partnership with various organizations. He has managed to enroll needy patients in the National Hospital Insurance Fund to enable them to get treatment and set up a shelter to cater to patients who travel far for chemotherapy to ensure that they don't miss their cycles. He is also collaborating with countries in an aim to focus on prevention and health promotion measures through screening services and awareness campaigns. His passion for holistic care is impeccable." Dr. Asira is the CEO, Executive Director of the ICI, the International Cancer Institute, that has cancer care and control activities and programs with various strategic partners in sub-Saharan Africa. He's also the Program Director and PI of Blueprint for Innovative Access Program, which brings together various implementing partners working on a cancer project in one geographical region across the continuum of the patient's journey. In addition to increased personalized medicine and optimized standards of care in Africa, he is the Program Director for the Shining Tower Program, a partnership between ICI and Roche, working in over 15 countries in Kenya to improve education, research, and training in cancer across all cadres of HCP, enhance early detection, promote HPV screening in cervical cancer programs, and provide diagnostics and therapeutics and enhance cancer research. Through Africa-wide virtual preceptorships trainings, ICI has created more than 50 online preceptorship modules with over 2,000 trained across 14 countries in Africa. And from 2011 to 2019, he was the director of AMPATH Kenya. He successfully conceptualized, spearheaded, and developed infrastructure for telemedicine, fellowship programs, and nursing and middle-level trainings in Eldoret, created a hematology oncology outreach program to various sites in Western Kenya, and participated in the development of the Kenyan National Cancer Control Policies and Guidelines by the Ministry of Health, amongst many research projects and programs. It is my great delight and pleasure to congratulate and award Dr. Asira on the 2020 Rachel Perlin Award, and we look forward to hearing your talk.
Thank you so much. Let me share my screen. It's a great honor to be part of this symposium, but most importantly, to be honored with this great honor. We do what we do because of the love of the patients that we see in clinics. And so when you get to be among such a group like Dr. Rachel Perlin and all the other awardees that have ever received this, I can just say I'm humbled. So I'll talk a little bit about some of the focused areas in which we do. So within ICI, we have several core focus areas of global oncology, and we look at it as a continuum of patient care and across various gaps that exist, as we've just listened to a wonderful discussion just a couple of minutes before. And this looks at clinical care, education and training. We span across research, partnerships, advocacy, policy, because influencing policy is one of the most important things in terms of sustainability, as well as funding and strengthening of public healthcare systems. But there are also several cross-cutting themes like leadership and administration. Multidisciplinary teams should not just stop at discussing patients, but should also go into all these core areas and even in the partnerships and advocacy, community engagement, ensuring we have sustainable models, data, health economics, and financing of the activities that we do. Just a little bit, a few seconds about International Cancer Institute. We've got 3 major centers: Center for Data, Training, and Research. We've got a Center for Clinical Care and Community Outreach, which houses the clinical care and diagnostics. And then within it, we have Office of Community Outreach, where we have several projects, as we've mentioned. One of the projects that I would highlight is the Empower and Shining Tower projects, as well as Blueprint. That are some of the things that we've just mentioned. And with the Empower project is as a result of partnership between the County First Ladies Association of Kenya. We have more than 45 County First Ladies, and then Africa Cancer Foundation, International Cancer Institute, Women for Cancer, and Roche. And this partnership really centers around very personalized patient care, but also embedding all our activities within the healthcare system that is existing. And we also have the Wellness Center, which I'll mention a little about. These are more than 15 partnering counties with ICI. Marsabit is shaded yellow, but just a couple of weeks ago, we opened up a clinic in Marsabit, so that will be changed to green. So what do we do? Mainly, I concentrate my efforts together with a huge team that I have at International Cancer Institute in terms of screening, early detection services that we provide. Initially, before COVID, we were doing a lot of community-based activities, but now we've actually created various facility-based screening activities that go on even during this COVID period. We've realized that integration of activities that we do is very, very important. And so integrating these screening activities with hypertension and diabetes testing, we've realized has actually resulted in a greater yield in terms of the impact and also acceptability of these activities that we do, and as well as mental health, which is also one of the things we are looking at. We partner with First Ladies Association of Kenya, and these are some of the First Ladies. We realize the importance, especially in advocacy and sustainability of projects and programs. And through the County First Ladies Association and our Empower program, we are able to reach a lot more people, and they do more advocacy than any of us could have ever done within their systems. And also involving men at all levels of this, not only because prostate cancer is one of the most common causes of morbidity and mortality in cancer in men in our settings, but also because of the financial interplay between men and women and the cultural impact of involving men and making sure that they understand these projects, even if it's breast and cervical cancer control programs that they have. One of the areas that I love the most within our programs is mentorship. So offering mentorship, people cannot really talk about all these programs without the role of mentoring those centers. The mentorship is not a one-off, it's not a biopsy, it's actually a continuous longitudinal relationship that you maintain, not only with the clinics that we have, but also with the other healthcare providers within the system. So we have more than 200 faculty who are part of our virtual, not only virtual tumor boards, but also virtual education and training programs. And they also offer a lot of mentorship and skills training to the various centers. So this is one of the clinics here, and we have several doctors here in this clinic. Data, and we realize that nothing much, even when you walk to an office of a government official and you say that cervical cancer is the greatest killer in your county, they'll always ask you, where is the data? And it's always a chicken and egg kind of thing, because you're always thinking, oh, obviously I need to start working with you so that I can generate the data. However, they are also looking at where is the data so that we can work with you. And so we've been capturing data in all these centers through our electronic medical record system that we call EICI. And this is based off open MRS concept. And we've developed a lot of, through our software engineers and various groups, we've developed a lot of online forms that we use in various centers. So all our patients that we've been seeing over the last couple of years are all in electronic medical records. Within the trainings that we've done in 2019 and 2020, I honestly think the role of training is never enough. I mean, we can go for the next 50 years and we'll still not have enough oncologists, enough hematology, enough surgical oncologists, radiation oncologists to take care of the population. And therefore, a lot of the multidisciplinary approach in terms of training an entire cadres of staff is very important. And our training platform has been accessed by various countries, you can see Burundi, Eswatini, Rwanda, Nigeria, Egypt, and several others, and have trained more than 2,000 healthcare professionals across multiple cadres of staff. And these trainings are both online training programs, but you also have some face-to-face skills training component as well as mentorship that is really important to improve quality of care. Virtual tumor boards, this is something we introduced 2.5 years ago, and we've actually been ongoing with it. And this is just one of the tumor boards that we held a couple of weeks ago. We always hold every Monday and Thursdays, Monday in the morning and Thursday in the afternoon. And now we are actually having attendance of more than 170 to 200 people joining. And so we are looking at ways in which, how do we transition these virtual tumor boards to make them more effective? Because now we know people have a lot of interest in being part of this, but they really help, especially in improving the standards of care and the quality of care that is given in these settings. And we invite various faculty that are really important in assisting us in doing this across sub-Saharan Africa. Linkages to optimal therapies through these trainings is also important. It's not just enough to train, but this skills training where we have groups of people that visit our site and various centers where we discuss and show proper ways of doing any of these activities, including even just chemotherapy administration, chemotherapy competency courses, has actually been shown to be very impactful in terms of maintaining quality care in those settings. What we do with cervical cancer, yes, a lot has been said, and we know the WHO call for 90-70-90 by 2030. And we really are looking at how can we eliminate this cervical cancer menace within our lifetime. And one of the ways that we've realized is that yes, VIVLI and all that is very important. However, even just the standardization of the training of colposcopy, lead training for gynecologists in our settings is also very crucial. So you can see here, Dr. Ganda, who is one of our gynecological oncologists as part of our faculty, training a team in VOI, and also going to the theater with some of our colleagues and training them on actual patients, but also having some skills training workshops that we hold from time to time, and obviously classroom trainings and case discussions as well as demonstrations. These and continued support through virtual tumor boards really improves the uptake of these trainings, but most importantly also improves the quality of care actually getting from these sites. One of the most innovative activities that we've come up with is the breast and surgical preceptorship, where we get surgeons from various parts of the country and countries, and we bring them together and we get some very prominent breast surgeons to come to these sites. We identify 5 or 6 patients whom we discuss through an MDT and provide the care for them, whether it's from sentinel lymph node biopsy to modified radical mastectomies to all these kind of skills. And they are actually shown practically on these skills. But we precede this with a multidisciplinary team meeting where this is discussed, and we have a pathologist, a radiologist, an oncologist, and several other cadres of staff. This kind of training that brings it very close to the people on the ground actually ends up showing quite a lot of these people that cancer is really one condition that it cannot be managed by one person. And we have to get away from the paradigm of I'm the only oncologist in the center, I'm the only one doing everything, to the fact that there is shared responsibility and improvement of outcomes if we can manage together. This is just a training opportunities that we have for 2021. And we have clinical preceptorships. As we mentioned earlier, we have more than 50 training preceptorships. They're all online at www.intercancer.com. And some of them, we also noticed that we have to also concentrate on non-clinical training programs as well, which includes supply chain and health commodities, grant proposal writing, introduction to data management, research methodology, advancing basic cancer registry, which we partnered with International Agency for Research in Cancer to hold virtually, as well as qualitative methods and ethics. So some of these programs which are non-clinical really have a huge implication, including epidemiology, biostatistics, have a huge implication in terms of the problem of the dearth of data in cancer care. How do we do diagnostics? We have established an ICI hub and spoke pathology service. So we have a full-fledged histopathology laboratory that is centrally located in Eldoret. And this pathology service is helping more than 15 sites in the country to ensure that for every breast cancer woman, we have ER, PR, and HER2 results for these patients. We have our Ventana machine here with our participation in our collaborative partnerships with Roche. We have a HPV DNA because without optimal diagnostics, really what kind of data are we collecting and what are we looking in terms of outcome measures, but also what kind of therapeutics are we asking for? And therefore, this has actually been shown to be very important. But not only do we do that, we've realized we cannot continue with this model of hub and spoke and everything being brought to central location. We've assisted in establishing a fully functional histopathology lab in a county called Meru. And our hope is that we'll establish more regional histopathology labs like this, and these ends up becoming centers of excellence in their own. And within those regions, they are actually able to access pathological service with very quick turnaround times. In these pathologies, once established, we also do a lot of training for not only the pathologists in the clinic, but also the histotechnicians to ensure that the pre-analyticals are solid and there is quality assurance in terms of diagnostics and care. And then we do survivorship care, palliative care and support groups. We've actually initiated about 20 or so support group meetings. But these three, we've actually initiated about 5 of them in the last year alone during the COVID pandemic. However, we have more than 20 across the country. We realize these are more important in terms of improving retention to clinics, improving access to information and awareness on various cancers, as also in treatment and advocacy. This is one of the things that really makes me very happy. We have a center called the Wellness Center, and we've partnered with Creation Hive in Eldoret, where when our patients come from far long distances to come to Eldoret for our care, we house them. We have 15 beds at the moment, and we house them for free through philanthropic efforts. But during this housing, they're also learning about tailoring, dressmaking, they're learning about animal husbandry, taking care of chicken, they're learning about financial management, bottlenecking, and various other learning experiences. I would say some of the programs, couldn't mention all of them here due to time limitation. We've supported establishing various programs with our various partners over the last 9 years. And these programs are spanning from oncology nursing training programs to oncology training programs for clinical officers, strengthening cancer registries in the country, patient navigation program. We've also established a clinical trial center here at ICI, but also myeloma and several others as listed. And some of our research activities that we are participating in for each of these programs that we create, we always have some research questions. Some of them is just implementation science, some of them are epidemiological reviews, and some of them are retrospective studies, prospective, and the rest. So we have quite a lot going on, including some phase 2 and phase 3 clinical trials in sickle cell and breast cancer, and soon onboarding esophageal cancer. So, and we've established also telemedicine and virtual tumor boards. We are in a discussion for digital pathology that we're establishing in our center to assist with the other centers and the rest of the team. I would really like to say that a lot of this work is not, you cannot do it alone. And as you can see, not only can you not do cancer alone, but also just the breadth of it is so much that involves a lot of inputs. And I must really start by acknowledging Professor Joe Mamlin, who has been my mentor over a quarter century in his leadership, establishment of one of the most successful HIV control program. I've learned so many lessons from that program, leveraging those lessons, my team and I, to help develop some programs in cancer control. There are several other people, and many to name, but Professor Dinesh Pendaka, Professor Anne Grice, Benda Kitheka, Dr. Zaisis, and notable faculty from Indiana University, including Professor Robert Einters and Professor Patrick Lair, our cancer patients. One of the greatest things that really give us the greatest support for our programs is actually the county government's leadership, the governors themselves, the county first ladies, as well as Ministry of Health of those counties. And working with cancer advocates and these groups, we realize that we can be creating programs that are more sustainable than projects that end with the end of funding. And most importantly, of course, the National Cancer Institute Center for Global Health, I've really interacted with quite a number of teams from there over the years, and they offer some of the most practical solutions to some of the problems that we face. And the Rachel Perlin Award Committee, thank you so much for thinking that the work that we do is worth recognition at this international stage. I can only say I'm truly, truly honored and humbled. Thank you.
Thank you, Dr. Asira, for that amazing presentation and for the work that you're doing on behalf of patients in your community, and for the work inspiring us today with your words. It is now my honor to present this year's 2021 Rachel Perlin Award to Dr. Carla Alfaro. Dr. Carla Alfaro is the Medical Director of Basic Health International, El Salvador, and the 2021 recipient. As she's a recognized expert in cervical cancer prevention and has pioneered the implementation of novel strategies to achieve large-scale screening combined with immediate treatment, saving lives across the globe. A quote from her nomination: Dr. Alfaro helped to create a paradigm for cervical cancer elimination that was adopted by the Salvadoran government and is being used as a blueprint for elimination in other settings. WHO and several other countries from around the world have sought Dr. Alfaro's guidance to formulate their own national policies. She was an author of the WHO's technical document on implementation and scaling for primary HPV testing. With her exceptional experience in field investigations, she continues to execute groundbreaking research even in the context of the COVID-19 pandemic, therefore allowing essential preventive services to continue. Dr. Alfaro has improved laboratory infrastructure for COVID-19 testing, which can later be used for HPV detection when the pandemic subsides. Dr. Alfaro has proven flexibility to lend public health expertise to the current crisis while continuing to lay the groundwork for the elimination of cervical cancer. Dr. Alfaro is Medical Director of Basic Health International, a nonprofit dedicated to the elimination of cervical cancer through research, advocacy, and outreach in low-income settings. Dr. Alfaro received her medical degree from Universidad Dr. Matias Delgado in El Salvador and obtained her master's degree from Universidad Evangelica de El Salvador. Over the last 10 years, Dr. Alfaro has worked tirelessly to bring cervical cancer screening, diagnosis, and treatment to women in low and middle-income countries, and has conducted pioneering research in El Salvador, Haiti, Colombia, and China. She is part of a team that pioneered the implementation of novel strategies to combine large-scale screening with immediate treatment in El Salvador. The paradigm pioneered by Dr. Alfaro and her colleagues was adopted by the government of El Salvador and is currently a national program. As part of her global health public work, Dr. Alfaro has been involved in the creation of technical and training manuals on HPV testing rotation for the WHO, the Pan American Health Organization, and the CDC. And most recently, she has brought her expertise and fieldwork experience to the implementation of COVID-19 testing in El Salvador. She's a dedicated physician, researcher, and public health advocate, and her work has touched the lives of countless women in El Salvador and around the world. Dr. Alfaro, congratulations on receiving the 2021 Rachel Perlin Award, and we look forward to your talk this morning.
Thank you so much for giving me this award and allowing me the opportunity to speak to you about my work. I have to say that when I was told that I needed to do this talk more personal, I felt a little nervous because I am not used to do that. But I will try to share my experience in the cervical cancer prevention field and how that has impacted my life and I hope the life of others. I live in El Salvador, a little country in Central America that has been struggling with the post-war effects and where inequalities are still present. Since I was young, I was aware of those inequalities and I wanted to help people that was living those difficult circumstances. That is why I went to med school, because I thought that I would be able to somehow make an impact and make little changes. When I graduated, I was interested in public health and I started to work with the Ministry of Health, where I saw those inequalities day to day. And I was contacted by Basic Health International and I was offered to work with them. I have to say that at the time I was not aware of their work and I got interested on their commitment to cervical cancer prevention and how they were working to improve women's access to health. This organization was founded by Dr. Miriam Kremer and was working closely with the Ministry of Health, introducing visual inspection with acetic acid and immediate treatment to the National Cervical Cancer Screening Program. Following the WHO recommendation at the time to include HPV testing, they were evaluating the possibility to do a project to implement that test. I thought that this was my opportunity to try to make an impact. And this is how my journey in the cervical cancer prevention world started. I want to highlight the importance of having mentors for me. I want to thank Dr. Miriam Kremer and Dr. Mauricio Massa for their guidance and support over the years. I feel very lucky that I was able to learn from their experience in the field and that they were willing to share all their knowledge with me. I am going to talk a little bit about the cervical cancer prevention program in El Salvador, or CAPE program. And we're going back 11 years. Cervical cancer was and still is one of the leading causes of death because of cancer in women around the world. The higher incidence rates are in developing countries. El Salvador reflected global inequities in cervical cancer prevention. It was the first cause of death due to cancer in women at the time. Despite the efforts, we had one of the lowest coverage rates in Latin America. An opportunity came to present a project to implement HPV testing through a donation program. And Basic Health International partnered with the Ministry of Health of El Salvador to make this happen. I was part of the team that worked on the proposal. This proposal was accepted, and that is how we started this transition to HPV testing with a pilot project. I want to highlight the impact of having collaborators from different institutions and advisors on this project. They were willing to work with us and give us their time to support our project. El Salvador was able to do a transition from a pilot project from one region to a national program. I was able to participate and lead different research projects around the CAPE program. And I learned that we need to show some evidence in order to make changes. Unfortunately, doing research in developing countries is not a common practice, and it can be very difficult, but not impossible. From the experience that I gained from the project and the research component, I was part of the technical committee that was evaluating the new national cervical cancer screening guidelines, showing the evidence and allowing us to include HPV testing and cryotherapy was a big accomplishment for the country. For us to achieve that, we had to put an extraordinary amount of work. At the beginning of CAPE, our organization had few personnel. I was able to collaborate on the creation of the training and logistics component of the program, training around 800 healthcare providers in cervical cancer prevention, the new screening approach, and cryotherapy treatment. I was also supervising the sites that were implementing the test and the labs that were processing the samples. As we were scaling up, we had to hire new personnel to help us with the training and supervision components. So we could train over 5,000 healthcare providers. All of this wouldn't be possible without all of my colleagues. Their commitment and hard work is invaluable for me. What is the status of cervical cancer today in El Salvador? We have a program running in 4 of the 5 regions of the country, and we are starting this year to intervene the last region, the metropolitan area. Through advocacy, the Ministry of Health included the test in their national budget to procure the test and also to deliver treatment to women. It is expected that 100,000 women will be screened each year. And last year, the Ministry of Health started to vaccinate girls, which also is a huge step in cervical cancer prevention. We are currently working to include self-sampling into the national guidelines because we think that this will make a bigger impact. Personally, it is very rewarding that women living in vulnerable situations are now able to access screening and adequate treatment. This is Yesenia, a cervical cancer survivor that was detected on one of the sites through HPV testing and visual assessment. She was referred to treatment. This is the kind of impact that I wanted to make. As part of the experience gained throughout the implementation program, we were able to collaborate with different institutions on the creation of manuals that will help other countries to implement a successful HPV screening program. I also have been working on other projects that will bring more options for screening and treatment for cervical cancer. Dr. Miriam Kramer has 2 NIH grants. We are conducting these research projects in China, El Salvador, and Colombia. And I'm excited to be part of this and coordinate different sites. We are testing cutting-edge technologies such as automated visual evaluation that could be potentially a lab-free point of care test. This initiative is led by NCI. We're also doing research on technologies that can substitute the need of gas for treatment, like thermal ablation that is already on the WHO guidelines. Personally, this has required a lot of my time away from my family, and I am grateful for them and for being very supportive all the time. Looking forward, the elimination strategy proposed by the World Health Organization is a historical moment. This is the first time that the world is committing to eliminate a cancer. More than 70 countries supported the decision from the WHO. And the targets for this elimination are to be able to vaccinate 90% of the girls by 15 years of age, to be able to screen 70% of women with high performance tests by 35 and 45 years of age, and to be able to treat 90% of the women identified with the disease. This initiative brings us hope. Aligning with the actions to make this happen, CUGH Health International is working to replicate El Salvador model in other developing countries. We are constantly looking for new technologies that can be point of care. And personally, I'm looking forward to lead more implementation and research projects. There are still challenges to overcome. Inequities related to cervical cancer prevention are still present. 90% of girls that receive at least one dose of HPV vaccine live in high-income countries. Less than 25% of LMICs introduced the vaccine in the national program. 30% of LMICs reported to have access to pathology and other services related to treatment versus 90% in high-income countries. We have the technologies available. It is our duty to make them available for developing countries. I want to give this message to early career scientists that are working in developing countries. Disparities exist in LMICs. Not all countries have financial and human resources, and we need to understand that. We also need to understand how research can impact on decision making. We've seen it. Advocacy is very important, and we need to advocate to conduct implementation research in those settings. It will take time. It took us 10 years to get where we are. There will be mistakes. We need to learn from them and take action. I want to have a future without cervical cancer. My girls are my inspiration at this moment. I want all girls to have the chance they deserve and that they don't have right now. This is a preventable disease. We have the technology. We need to make this happen. Thank you to all the organizations that are collaborating with this mission. And thank you so much again. It is my honor and privilege to receive this important recognition.
Thank you, Dr. Alfaro, for that very inspiring and impactful work that you presented. And congratulations on the award. We do have time for questions, and I invite folks to pose questions in the Q&A, but perhaps I'll start first, pose question to both of you, which is, how would you advise trainees who are working in global oncology or global cancer research, based on your experiences, the challenges and the successes you've had, how would you advise them in their career as they look forward to this challenging work in their projects in the field, looking for mentors? Maybe we could start with Dr. Alfaro first and then Dr. Asira.
Oh, thank you so much. So from my point of view, it is important aligning yourself with a cause or something that you really believe or you are passionate about. Wherever you are, if it's an academic place or other, finding a mentor is key to help you navigate this increasing complex environment. It is also important not to be afraid and to be patient, not expecting rapid results and not to discourage about how things will turn, because it is not an easy path. It will always depend on the resources that are available. There is the ideal and there is the real world. But even if you think that you are not making enough changes, and at the end, everything counts, and those little changes can lead you to big accomplishments.
So I would say I totally agree with Carla. It's a lot of resilience, a lot of slow changes. However, when there is traction in anything that you do, and when things start being successful, a lot of people want to own them. And being part of a partnership that you don't really mind who owns, as long as something is working, is very, very important. The other thing and Carla mentioned this, and I totally agree, is mentorship. A mentor is key. And for those young in global oncology, the good news is that 10 years ago, there was very little traction and organized global oncology fora. Now I know the recommendations by ASCO, and I was part of this team that developed recommendations for global oncology as a discipline. It's very, very important, and I'm seeing a lot more people putting a little bit more weight on that. When you look at a mentor, the mentor doesn't have necessarily to be an oncologist if you plan to do oncology. Global health, as long as there's a mentor who has a lot of passion for something within global health, can actually be able to mentor you, because I think the experiences we all experience are pretty much the same. Limited resources, prioritization, working into financing models, looking at even non-traditional partners that will end up being your partner in terms of cancer care. Who knew that we'll be talking to medicine men in clinics to really talk to them about the importance of screening and sending people from their communities to come for screening. And most importantly, no one size fits all. And so one thing I've realized is that even within the same country, when I go to these 15 different counties, each county trying to do a very major gap analysis to figure out what do they have, what are the low-hanging fruits, what are some of the things you can do very quickly. And those things, once they start seeing the positivity of those things you do, they are interested in biting a bigger chunk and giving you more space to do exactly what you want to do. So there is so much more to work, and there are very few people working in this space, and we are looking for more assistance. I would tell you, this is a very good road, and welcome to it. However, just be strong and resilient.
Thank you both. A couple questions in the Q&A. Maybe feel free to either of you take this about, how about HPV-mediated cancers in young men or in men in general, or how is that being addressed in your various projects or in programs?
So in mine, we haven't actually addressed that question, although we are seeing quite a number of men with HPV-related, like penile cancers and all that. Currently now, in all the screening facilities, initially we were just doing visual inspection with acetic acid, but with our partnership in Shining Tower project, we are actually able to do HPV, and we are doing HPV testing at a central location, as well as doing cytology for women above 30. So for above 50. So for us, I think that will be the next easy progression. We want to be able to really turn the tide on cervical cancer in the women in our setting as we look for the boys. And then even the vaccination, the government has done a little bit of demonstration projects in various centers on vaccinating the girls, however, the boys not yet. So I think this is an area that is open for any collaborative efforts and people who are interested in it.
Dr. Alfaro, did you want to comment?
Related to HPV mediated in young men, I mean, right now here in El Salvador, for example, we started vaccination last year, And this is something that we really need to address. For now, vaccination is just happening in little girls, and this is because of the resources that we have. We don't have, the government doesn't have the financial to be able to vaccinate young men. But definitely this is something that needs to be done, and it will take time, of course. Governments need to find the means to be able to implement it. It was a huge step. I mean, we were talking about the vaccine for a long time, and it happened last year. And we hope that the government will also include young men into the vaccination program.
Right, and speaking to the vaccine, as many people are aware, there's a question about is an issue specific, especially in low-income countries, in particular with this era of COVID-19. I think the question maybe, and there's specifically here is, what are your opinions about the HPV vaccine in terms of the major challenges in the rollout? How does that either dovetail or parallel or work with the COVID-19 vaccine that's also being rolled out through COVAX and other programs? I wonder if you guys both could comment on that, if you think there are particular issues to discuss and raise awareness about that in some ways could work well in terms of potentially vaccination campaigns and what we could learn from this in general.
Can I go? So from our center, what we've realized is that any of these very important progress that is being made in terms of cervical cancer prevention, or any prevention for that matter in cancer care, we've realized our communities are actually very eager to take this up. However, it depends on how you approach the community. So part of the work that we do is that in our outreach activities, not only do we work with the county governments and their leadership, but we also work with community health workers. And some of these people are really opinion leaders and opinion shakers in terms of any activity or intervention you need. And it only involves you explaining to them very well until they understand, and you come up with some material that is actually easy to understand in the language. Like we've seen even when we are doing our HPV testing, the uptake in some of the counties that we are doing is almost 100%. Actually, the problem we have is the enough facilities and enough reagents and enough kits to take them around to everyone. So my thought is that even if you don't give good communication from the beginning about the relevance and importance of this, you give room for a lot of conjecture and innuendos about the vaccine, and the uptake ends up being hampered. So for anything that we've ever done with the community, I've actually realized honesty and being very on the ground and meeting the true people who are leadership, whether it's the church leaders, whether it's the pastors, whether it's the Catholic priests. So these are non-traditional, for some, non-traditional partners that you would not even imagine in med school you would be working with, but they are the people to be convinced and be told what is the relevance of what you are doing. And usually they help in the uptake in the community. That's what my position is.
And I agree with Dr. Asirwa. I mean, education is needed in order to be able to deploy any vaccine. And you have to educate healthcare providers. You have to because they are they work at the community. So, and if they don't know why it is important to use the vaccine, then they will not be able to replicate this information, and they will not convince people to get it. It's not just community health education, it's also people at the community that will receive the vaccines need to be educated. That it's really important, and it won't work if you don't do that.
Thank you both. I wonder if you could both speak to briefly what, as the pandemic has been disruptive to many programs across the world, especially collaborations and partnerships between high-income countries and low-income countries in terms of travel. How do you see the changes and the challenges of the last year continuing or unfolding with regard to your specific goals for your programs?
Yeah, so I believe like nobody expected this pandemic to happen, right? So it's been hard. I mean, regarding cervical cancer screening, for example, here in El Salvador, we were able to implement this in different regions of the country, but it stopped at some point last year. Screening stopped for 6 months, and treatment also, because all the resources, we have limited resources, as those were focused on combat the COVID-19 pandemic. So it has deeply affected. Probably we will encounter some problems to get this like at the point that we were last year before this happened, and it will require a lot of work, and it will require a lot of like partners that get involved on this, because it will be hard. I mean, it's still here, and even though there is all this screening and treatments are being like slowly back to normal, I mean, they haven't yet. So we will need to work a lot to be able to get where we were before the pandemic.
So from my end, I would say that COVID-19 has really taught us a lot. It has taught us that we can be very innovative. People can be very resourceful, actually. And I look at it even just from my team and the collaborating partners. In 2019, we trained 579 healthcare professionals. In 2020, during COVID, we trained well above 2,000 healthcare professionals. And I think because we've taken everything online, and we can reach a lot more people. Right now, when we are doing our virtual team boards, we have people logging in from China, logging in from South Africa, Lesotho. The interesting part is that we have still continued doing some skills training face-to-face workshop, of course, depending on the WHO and the Ministry of Health recommendations at the time. But I think that this COVID-19 has just shown that we can actually do more. And also it has opened a lot more room for South-South collaborations too, in addition to just high-income countries and lower middle-income countries, because now we have partnerships with countries like Rwanda, like Eswatini. We are doing some work with Burundi. I think it also shows that you can look within your environment and see some of the professionals that can actually collaborate and be able to come and do some of the trainings you are doing. So I think it's a bad thing, of course, and nobody expected this COVID-19, but just noticing that the innovation within people and the resilience and the fact that programs have continued, I would say, of course, even programs like ours, community programs like cervical cancer, we used to do, mass events where we go to a place and we have 1,500 women that we are taking for screening at a mass event. We can't do that anymore. But what have we done? We've actually created more facility-based screening programs. And last year during COVID-19, we screened over 20,000 women. However, we used to screen 26, 30,000. It just shows that although the numbers have come down, there are ways to go around it to still take the care to the people.
Thank you both. A couple of follow-up questions in terms of the plan or raising HPV awareness among men. I don't know if Dr. Alfaro, you want to comment specifically on this, or if there are plans in place to think about that.
Yeah, so part of our program here, education component, like I said, it is really important, and we're just not educating women. We are educating also men, because the problem here, it's like culturally speaking, we have the machism that is present, and sometimes women are not allowed to get their screening because men don't let them do that. So we try also not to educate women about the importance of getting a test, for example. We also try to approach men and educate them about the importance of getting for their wife or getting a test and be treated too. And the fact that sometimes, for example, it is a man provider, that's one of the limitations. And we're working to solve that, because a lot of women that don't want to be screened, it's because of that reason. And we're trying to get some attention to the self-sampling, which we think that it will solve a lot of these issues that we have regarding that.
Dr. Sarah, did you want
from my end, I totally agree with Alfaro. The thing that we've realized, not only for cervical cancer, but also just cancer control, involving men is crucial. And we involve men at every point, whether it's breast cancer, cervical, and the like. And remember, there's quite a lot of power balances, and especially the more you go into the inner rural communities, the more imbalanced it is. And if you really, really want the women to have an increased uptake of any of the interventions, then the men must be involved.
Thank you both. I wonder if you both could comment on what you think the role of technology and whether or not mobile technology or mobile health is, you think it will be particularly impactful or in your community and your work, or what types of technology you think have affected your work positively. It sounds like doing virtual training and tumor boards has been very impactful for Chite, and I wonder, Carla, as well for you, what do you see the role of technology in your community and in the work that you have there unfolding in the future? If you had some, magic wand to create something new, what would that be that could impact your patients and your research on the ground?
So currently, the Ministry of Health is working on telehealth, for example. So it's something that it's been on the table since this pandemic hit. We think that we are doing trying to do some research around it and how we could use technology to improve screening, for example. We are trying to, also we are moving from training people to do it like via Zoom, for example, because we were at that point last year where we were training people, providers, to do treatments, cryotherapy specifically on women, and that stopped. So we had to find another way to do it, and we use technology to do it. We are using currently also a mobile ODT, which is a device that is used to do consultations when providers are in the clinic and they are treating patients. If they have any doubts, they can communicate with somebody. They can give them like a more what to do with that patient if it needs to be referred or it needs to be treated at the time. So I think that it probably will not be easy because you need to have the technology available, but I think it can be done. It will take time. Probably like it took like to move from VIA or cytology to this HPV testing and immediate treatment. But I think it definitely can be done.
Thank you. Dr. Sarah, would you like to comment?
Yes, so from our standpoint, technology really is very important in this. And whether it's management of data, the data collection, the electronic medical records are really helpful even in hypothesis generation, impact, and the framework evaluation. Because these paper-based programs we've been trying for so long, and not many people feel or check all the boxes, and part of it is the clinics are so busy. But I'm also looking at the digital platform, like the digital pathology, coming in very handy as one of the things. And if I had a magic wand, one of the good things that we are incorporating moving forward as from April is actually telemedicine with a company from Japan, and how to look at how can this telemedicine platform assist in our tumor boards. Because when you have 170 people attending a tumor board, really you're not discussing, this is pretty much like it's a church service. And so one of the ways we want to look at is how can we have 24/7 virtual case discussions through a platform like telemedicine. And lastly, artificial intelligence, especially, we are collecting a lot of pictures and a lot of colposcopic findings. And if we are able to put all these together, that forms part of our data science data framework, and having artificial intelligence to assist algorithmic evaluation that can actually be taken to sites where you don't really have all the specialists. That will be very important. And most importantly, can we have these digital platforms for clinical trial support? So teams coming together and assisting in clinical trials, because you realize that there are so many things we could be doing, but the same person is is seeing all these patients who are coming to clinic. And so it's important to have some platforms that take away the stress of biostatistics, epidemiology, or even sample size calculation and all this stuff through some form of a digital framework that others can log on to. Thank you.
Well, thank you both. I feel very inspired by your work, and I'm sure that the rest of the attendees do as well. We want to congratulate you both on this, on the Rachel Perlin Awards for 2020 and 2021. And I hope that we can all get together next year in time to celebrate and discuss all together. I want to thank the NCI Center for Global Health and the other organizers for the opportunity to chair this session, and for the comments of Dr. Asira and Dr. Alfaro, who are really providing incredible impact in the world and showing us what can be done. And we really want to thank them. I'll now turn it over to the final session to Dr. Mutebe and Dr. Gopal to provide final remarks. Thank you.
Great. Thanks so much to Dr. Huang for chairing that session, and congratulations again to Drs. Alfaro and Asirwa. I think it was great to hear about the work that, I think richly deserved the Perlin Award, both in 2020 and 2021. I wanted to just say a couple of things before handing back over to Dr. Mutebi to close out the meeting. The first is that, as you'll see in the chat box, the posters, so the 101, I think, posters that are included in the scientific program this year will remain available at the conference website. So I would encourage people to visit those, particularly in your specific areas of interest, and try to make connections. I think that will continue to be important as we all struggle with this virtual existence for a bit longer. There will also be a meeting survey, and the link again is shown at the chat. So if people can find time to do the 10-minute anonymous survey, I think that will really help us evaluate this symposium, how well this program really is serving the needs of the community, and also how we might think about modifying either the platform or the program for next year's meeting. So with that, I want to just say a couple of things before handing over to Miriam. The first is, thank everyone for joining. Obviously, we're continuing to struggle with COVID. Most of us are participating in this meeting from home, although I think in many of our settings we can start to see the hopeful end of that sometime soon. I think in parallel, there's clearly been this global movement for racial equity. I think all of that has really been reflected in some of the important discussions that have occurred during these 2 days, and I think are really prompting us to think about and reflect on, some of the things that, some of the historical inequities, some of the problematic historical legacies, and how we can really consider those issues in developing a platform and programs that make sense for the future. We are certainly thinking about that a lot at the NCI, and in addition to COVID, emerging from COVID, and ongoing social justice discussions. Of course, the 50th anniversary of the National Cancer Act and the 10th anniversary of the Center for Global Health are there's a synergy of all of these milestones coming together that I think are really allowing us to think about a future-oriented agenda in, I think, some really deep and useful ways. So I'd really like to thank everyone for joining, thank the organizing committee for putting together this 9th annual symposium on global cancer research, and for inviting me to participate. I think, we've really had 2 days of great discussions that have really brought a lot of these issues to the fore, and I think will inform a lot of the things that the ways in which we choose to address the ongoing gaps in global cancer research and control going forward. One of the things I'm particularly delighted by is how inclusive and diverse the speakers in this 2-day program have been. I think that really reflects a commitment on the part of this community to equity, diversity, and inclusion. Again, I think topics that we were all thinking about in our own programs and institutions. And so reflecting that, I'd like to hand back over to Dr. Mutebi, who served as a highly capable host for this meeting, and invite her to close out what has been, I think, a really remarkable 2 days. Miriam, over to you.
Thanks, Dr. Gopal. And I think just to echo what you've said, it's been an incredible, I think, 2 days, just sort of hearing all these different discussions. And I think I would particularly want to thank all our speakers and all the participants for really, really, committing to engaging with these difficult and sometimes uncomfortable conversations. And I think we've, as Dr. Gopal has mentioned, we've confronted a bit of, hard truths around colonial legacies, or whether it's neo-colonial constructs. And we've looked at previous inequities and, past partnership models, and again, failed translation to and dissemination of our research results. And I think we've also heard about the very fleeting nature of some of our interventions, and that's because we're not necessarily looking at them through the lens of sustainability. We're looking at it more through, the myopic view of, the 4-year, whatever cycle it is for grants and thinking. But I think more importantly, and I think that this is the bit that I'm most excited about, we've heard about successes and learned models for building towards resilience in the research we conduct, and equity and parity in our research collaborations. And I think we've probably gotten enough just to start the conversation going. And I'm hoping that this conversation will go beyond the scope, and we will continue to engage with these important and critical questions. I want to thank the steering committee for the ASGCR 2021, including the US National Cancer Institute Center for Global Health, the CUGH, the Duncan Comprehensive Cancer Center at the Baylor College of Medicine, the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins University, the University of Texas MD Anderson Center, the American Society of Clinical Oncology, the American Association for Cancer Research, and the international collaborators of these institutions from the Ministry of Health in Mozambique, the Aga Khan University Hospital in Nairobi, Kenya, and the Tulane Health Officers for Latin America. Just as a quick reminder, again, to take the survey that is reflected in the chat. Next year will mark the 10th anniversary of the annual Symposium on Global Cancer Research, and we're looking forward to seeing you all in 2022. Now, in closing, after a night of balancing my chakras and trying to come up with something sufficiently profound that would have you motivated and run out to take resilience or equity by the horns, I leave you with my famous bumper sticker from Glendon Doyle Melton, who says, "These things will be hard, but we can do hard things." So I'd want to just inspire you all to keep pushing, keep pushing the envelope, and stay safe out there. Thank you and good night.